Cool. Okay, I think we're just about ready to start. We might have a few more stragglers. Welcome everybody. Every year that we do this, it gets a little bit better organised, a little more content. The tech gets better. So hopefully we can say that this year is the year we've perfected it. My name's Narayan. I'm an interventional radiologist from St Thomas's in London, and I've got some friends, some colleagues and friends to join today to hopefully talk to you a little bit about IVUS, but not just IVUS itself, but also IVUS in the broader context of chronic limb-threatening ischemia, general PAD treatment. We've got 2.5 days of program lined up for you, and I'll just run through what we're going to do today. So we'll start off with a little intro from me, and then Mark Portu, who leads the peripheral intervention service at Royal Free Hospital in London, is going to talk to us a little bit about the disease we're all treating, set the scene a little bit. I appreciate there are some people in the room who have never or hardly ever used IVUS before, so we'll spend some time just going through the very basics of image interpretation, really how the very sort of bare bones of how to read an IVUS image, and then we'll get a little bit more into it with Mark coming back to talk about his experience of using IVUS in CLTI treatment particularly, which is where we feel that it can offer a lot of benefit. There'll be a brief break for coffee, and then I'll hand over to my good friend and colleague Ash Patel, who I've spent far too long in theatres with over the last sort of decade, figuring all of this stuff out, and he's going to talk about how he uses IVUS to assess diffuse disease and plan treatment, and then hand over to my colleague Conrad von Stempel, who is basically an IR who does exactly the same thing that I do in South London, in North London, and he's going to walk you through a sort of representative case to show how IVUS fits in his workflow. And then finally for today, this is actually one of the most interesting parts of the day. I'm going to introduce again a really good friend and colleague, Becky Sanford, who I hope she won't mind me saying is a real surgeon's surgeon. But every time she picks up a new endovascular device, picks it because it works for this reason. And it's really interesting for us every year to have someone who's just started using IVUS explain what exactly they found it to be a benefit for in their practice. And we found in previous years that that's been one of the most valuable parts of the day for the whole group. And then hopefully you can join us all for dinner this evening in the restaurant around the corner. Cool. Before we get into it, I just want to do a quick run around the room, just sort of more for our own preparation for the workshops tomorrow, just to see where everybody's come from and what your sort of level of experience with IVUS is, because that will help us to sort of tailor the workshops a little bit. So we'll start on this side, because unfortunately I know most of this lot already. So yeah, where are you guys from? And okay. In PAD. Cool. Okay. Very nice. I think said it all. Should we?
We're from the same.
Yep, you're on.
Okay. We're from the same hospital, so like the colleague said, we use IVUS generally on more central pathology and maybe a little for the iliac venous pathology, but on peripheral arterial pathology, we barely even used it.
Cool. Yeah. All right. Let's go around a little bit.
Yeah. Are you from the same hospital, right?
Yes, we are both from the same hospital, and we will start with the IVUS next month.
Perfect.
So we are
okay.
very interesting.
So right from the beginning.
Yes.
Perfect. Okay.
Hello, we are from Knut from Sweden. We have IVUS and use it now and then. But I hope after this course we will
maybe feel a bit more often to use.
Yes.
Cool.
Hi, my name is Jan Süß. I come from Germany, from Eschweiler. It's between Aachen and Cologne, deep in the west. And I'm not experienced with IVUS. I take this workshop to learn it and maybe to introduce it in our clinic.
Hello, we are from Slovakia, and I'm sales representative, and these are our doctors from Slovakia.
In our hospital, we are starting with IVUS, so not many experience so far.
The same as my colleague. We have not much experience with IVUS.
Perfect. Okay. I'm going to pass the mic on to this middle table here, maybe, or oh yeah, we can go at the back.
Hi, my name is Feng Ying. I'm training as a third-year resident in vascular surgery in Berlin. I've never used IVUS.
Yeah, hello, my name is Stefan. I'm a vascular surgeon, and we use IVUS quite a lot, but mainly for the central veins, quite rarely in peripheral arteries so far.
My name is Frans. I'm from Västerås General Hospital, Sweden. We use IVUS mostly for venous cases, but sometimes for peripheral arteries. So not a lot of peripheral artery experience.
I'm working as a resident physician in a community hospital in Vienna, and I don't have any on-hands experience with IVUS, but we are eager to implement IVUS in our complex endovascular PAD cases, so we are eager to learn it.
Same here, also from Vienna, no previous IVUS experience.
Hello, I'm Antti from Finland, Oulu, Finland, so northern part of Finland, and we just got IVUS about a couple of months ago, so we don't really have a routine with it yet, so haven't been using it much. Maybe some venous cases we tried it sometimes, but it would be nice to learn what the benefits are and how we could use it.
Sure, hopefully we can help you with that.
Hello, Heikki from Southwest Finland. We have used a few catheters and we are here to learn how to use more.
Hi, I'm Nikos Konstantinou. I'm here from the LMU in Munich. We've mostly used it for the aortic dissection, complex aortic dissection cases. BTK, I find it very useful, and I'm here to get convinced to start using it in the SFA.
I'm Mike Robinson. I work at GSTT, so I'm developing my practice with IVUS under the mentorship of 3 of the speakers today. So,
Tom, I'm from Ipswich, Colchester in the UK, and I've got a little bit of experience using it in venous, but no arterial. So,
no experience, first-time user. Looking forward to things. Thank you.
Hello, Mohammed. I am working in Germany, not far from here. I have experience from the cardiology, but I used this rarely in the peripheral.
I'm Deepak, and I come from India, and we recently got an IVUS. Been using it mainly for venous cases, iliacs, and looking forward to this meeting.
Excellent. So we've got then quite a mixed group, and a lot of people really starting from scratch. So hopefully with the workshops, we've got the IVUS software loaded onto tablets, so you can actually play with the software that's used in real life without a patient being there giving the additional stress of that. So I hope you all find that really useful. It's interesting to see how all people have come towards using IVUS for PAD. In our hospital, it started off again down the venous route, which I think a lot of you said that we started using for venous and then realized that it might actually be appropriate for somewhere else, and slowly now, after some time, taking some steps into using it for aortic pathology. But it's interesting, everybody comes to it from a different angle. Good. Okay, so just before we start, I just want to say thanks to Philips for organizing this, and it is mainly an in-person workshop, but there are also, you've noticed from the cameras around the room, recording this which is going out live on Vascupedia as well, but most of it will be all about this stuff rather than you guys, so don't feel too shy. Just ask any questions you want. We'll try and keep it as informal as possible with the microphones moving around, and the next 2 days are not just us talking to you. It should be as much of a discussion as possible, because believe me, we learn as much from you guys as you learn from us. We're not really here to sell you IVUS. I think the information you get from it sells yourself, but what we are here for is to teach you how to use it if you haven't used it already. And then the really big question, because all of us can pick it up very quickly, is when to use it. And I think that's the real question that all of us want to know about. Where is it going to make the actual difference in our cases for patients? And hopefully over the next couple of days we can come to some kind of consensus about that. Good. All right. I'd like to hand over to Mark Portu now. He's the lead of the lower limb revascularization service at Royal Free, using IVUS for a few years now. and going to give you a very interesting perspective on the disease that we're treating.
It works, fantastic. Good afternoon, everybody. So if everybody here in the room and everybody at home, welcome and thank you for having me. Thank you to Warren and Ali and everybody from the Philips Image-Guided Therapy team as well for having us. And it's my pleasure to talk to you not once but twice this afternoon. Got the after lunch slot, which is always tricky. You guys are nicely digesting your lunch, so I'll do our best to try and keep the energy up a little bit for you. So yeah, I'm going to talk to you a little bit about specifically the use of IVUS, not just in PAD, so in the sort of peripheral space, but specifically in critical limb ischemia. And hopefully, through some tenuous links, I'll take you with me. So this is me in the mornings as I walk into the handover. Some of you who I work with will testify that this is pretty much my greeting to all of my colleagues first thing in the morning. That's assuming I turn up for handover in the first place. But it also illustrates the importance of getting all the information. I wasn't here to embarrass the future king, but really to explain that we all jumped to a certain conclusion and we all made the wrong choice. It just goes to show that getting a different perspective can lead to a completely different interpretation. I told you it was tenuous, didn't I? Okay. I'm going to take you back to the balmy, yes, no, I know, I'm sorry. I'll take you back to the balmy late spring of 2002 and the Europa League semi-final, delicately poised. First leg, my beloved West Ham, 2-1 down from the home leg, now in Frankfurt. Very much on top. And then 15 minutes into the game, this happens. Ball comes over the top, and our veteran defender, Aaron Cresswell, gets caught the wrong side of the youthful Frankfurt striker. He grabs him. He pulls him down. And the ref immediately shows a yellow card. Thousands of people in the stadium, along with millions at home, including myself, breathed a sigh of relief, thinking, he was the last defender, wasn't he? Looks like he's got away with that one. Lenient ref. But no, he gets a call in his ear. Perhaps you better look at that again, ref. He goes over to the sidelines and reviews the VAR monitor. He is the last defender. That was blatant. It was rescinded and a red card was correctly shown. Heartbreak for the Hammers, but ultimately justice served. Frankfurt went on to win the game 2-0, and as you will know, particularly my German colleagues, they lifted the trophy in the final. What does that show you? Again, making the right decisions on the basis of all of the information available. And it isn't just football, is it? Where we've got VAR. Think about the decision review system in cricket. Think about Hawkeye in tennis. Why would we spend so much time and effort in getting the right decision in sport and not apply the same thing to healthcare? Okay, this is where it gets a little, hopefully, less tenuous now. We're all experts in the room. You don't need me to talk to you about this subject, but really, just to make sure we're starting off from the same point of view, what do we mean by CLTI, or chronic limb-threatening ischemia? Well, we mean inadequate perfusion to maintain tissue integrity or prevent ischemic pain at rest. With a variety of different classification systems, the one we typically use, of course, is the Rutherford classification. That one. And we're talking here about Rutherford 4 to 6. Another ways of otherwise of defining it, but essentially we're talking, aren't we, about rest pain or tissue loss. We're talking about preventing what's on the right-hand side of your screen, major amputation. And this is by intervening in a definitive and decisive way on those people that present with really quite a dire situation. These are the populations we're talking about with CLTI. Again, you don't need me to explain this, but we will all have some variation in the way we approach this tricky problem. I, for instance, very much rely on a duplex preoperatively, particularly for the infrainguinal disease. Anything I would say aortoiliac, I will get a CT angiogram, but certainly for the infrainguinal work, the arterial duplex scan is where I start. But I'm aware from traveling and from speaking to colleagues from other parts of the world that many people rely on cross-sectional imaging. Who does, for instance? Who always does a CT? Okay, it's interesting because we've got differences already, which I'm kind of glad about, otherwise this was a waste of time. And you're also aware of the various different ways that we choose to approach these, and each one will depend on several factors: our own personal experiences, what our unit culture is, what our patient looks like, and again, there's not really a right or wrong way, I would say. And certainly, within the last 3 years, these two very seminal and very well-conducted randomized controlled trials, I would say, have failed to conclusively answer the question as to whether or not it's best to have an endo or an open first policy when it comes to CLTI. I personally wasn't that bothered by either, and I can tell you why before I commit surgical heresy. It's because of if you look at the exclusion criteria for both studies, both, it would be fair to say, had the same sort of opt-out criteria for the populations, which, for me, forms about 85% of our workload. So if 85% of our patients would not have been randomizable to the Basel II or the BEST CLI study, then clearly I can't really apply those findings to what it is we do, which is where I hope you'll see the relevance of what I'm saying. Irrespective of how you decide to treat CLTI, it's fair to say that we are losing the battle when it comes to survival. I mean, depending on where you get this information from, anything between 15 and 40% 1-year mortality. And certainly 4 to 5 year mortality well in excess of 50%. You name me one condition that has a 5-year survival worse than 50%. It doesn't have the public awareness, that doesn't have the funding, that doesn't have genuine attempts at trying to improve those outcomes. If this were a cancer, for instance, that was treatable, then I suspect what you would find of lots of people wearing glittery bras and walking through Hyde Park at night, instead of Conrad, who just does that for fun. No, what we are looking at here is very much the poor relation of the cardiovascular disease spectrum, and we are not really winning that battle. You can say that's possibly an argument for another day, but what I think it illustrates is the population we're talking about. Okay, this is really where I'm going with this. You'll be pleased to hear I have a point. This particular study looked retrospectively at the characteristics that led to a particular decision as to whether or not to proceed to an endo first or an open first revascularization policy. And it wouldn't surprise you to see, and it's a little bit small in the corner there, I'll read it out for you, that age, the more CLTI, extreme tissue loss end of the spectrum, smokers, poor functional status, people that are diabetic and on dialysis, very much favored an endo first policy. Doesn't sound controversial, does it? If you cross-reference that with the characteristics from the anesthetic assessments of those who are at the highest procedural risk, age, diabetes, poor functional status, smoking, does it sound like anyone you know? That, I suspect, I was hoping for a bit of audience participation there, hopefully, but I suspect you're still thinking about that. So where does IVUS fit in then? Now I've painted this in overwhelmingly bleak picture for you. Well, it means that we are dealing with a population which has a very limited life expectancy. We are doing high-risk procedures on high-risk patients. So anything we can do to reduce that perioperative risk. So, for instance, adopting an endovascular first policy, which is what we have done in our unit at the Royal Free. Reducing the amount of contrast we use. It will come as no surprise that a lot of our patients have got impaired renal function. Our job is to get flow to the toe, which means target arterial path, which means treat optimally every level of disease. And you're often going to have one go at that in a CLTI population. So we're talking complex procedures in complex patients. We want to make sure we do it right, getting it right at the first sitting, because you may not get that second go. And likewise, if we do get it right, what we don't want to be doing is coming back frequently in order to correct the mistakes of the first or when things have progressed. I would also say that I don't know about the other parts of Europe or India, but where we are, it makes a lot more sense with the number of people that we have got to treat to try and do 3 complex endovascular procedures on our hybrid operating list versus maybe 1 femdistal bypass. So in terms of patient flow, it makes sense for us to do a higher number of shorter procedures, hopefully with a similar outcome. In our operating room, we operate under a lot of restrictions. And you can see from this photo, I'm very, very pleased with my new TSM touchpad, by the way. Very happy with my ability to drive the IVUS under the sterile drape there. But you can see we've got a mobile C-arm. You can see I cramp for space despite this being a hybrid facility. So everything we do really compromised. This is how I set things up. I don't know how everyone else does. Maybe you'll see that from some of the other speakers. But essentially this is the IVUS machine. I have the transducer that is strapped to the side of the table and my touchpad here enabling me to do everything that would have required an assistant to do on the monitor there. One of the criticisms I've heard in the past is that it can often slow the procedure down by doing IVUS. But it has been my recent experience of now having the touchpad that isn't the case. It can be done as you go. And that, I think, really does start to fit into what I'm talking about here in terms of bringing in a strategy to reduce perioperative risk and improve your decision making. In the UK, for those of you outside the UK, we finally have a national service framework. That is something with which we aspire to improve our service for peripheral artery disease, but specifically CLTI. And these are centered around targets that are, for inpatients, 5 days from diagnosis to definitive treatment, and in an outpatient situation, 14 days from referral to treatment. Now, the only way that I could think of us actually managing this was to start reducing some of the steps that we previously had in our pathway. Capturing people as well, I had to come up with these pretty looking diagrams centered around wounds, centered around those without wounds and potentially without diabetes as well. But ultimately, the way to save time in order to help remotely get near a 14-day pathway was to cut the number of steps down. And that is where IVUS fits into my workflow. So I already mentioned that I'm very happy when it comes to infrainguinal disease to start with an arterial duplex. That information I get from that is a brief understanding of where the anatomy, what the anatomical location of the problem is. But without the CT, what I'm using it for is to guide my access point. Thereafter, a combination of angiography and intravascular ultrasound enabled me to make decisions about lesion morphology and vessel prep technique, balloon sizing, and any further adjuncts that required. That's done in the perioperative phase, and it saves me a 3-week delay on getting an outpatient CT. That's it for now. I'm going to come back to you after Narayan's spoken, and we'll talk a little bit more about CLTI-specific IVUS. Okay? Thank you.
Lovely, thanks very much, Mark. So, now the next sort of 15-20 minutes or so is going to be mostly useful for the people in the room who have never used IVUS before. So those of you who have some little familiarity with it, bear with us. Maybe it'll be a bit of a chance to recap as well. We are going to talk about the basics of IVUS image acquisition and interpretation and a little bit about how you might fit it into your workflow. So let's see if this works. So, why intravascular imaging? Well, the reason we all started using IVUS is essentially because of the limitations of angiography. That angiography is essentially luminography. It only tells you what's happening in the lumen of the vessels that you're working in. And if you think about this compared to other disease systems in the body, this is actually quite bizarre. The stuff that you're treating is plaque on the wall of the artery, but you're using information about simply how much lumen there is in the artery and how fast the flow is to guide how you're going to treat something else that you can't really see. And if you try and apply this to any other area of medicine, you'll realize how bizarre it is. You don't get any info from angiography on plaque distribution. You don't get any info on plaque composition, which as we get more and more advanced tools to deal better with specific different types of plaque becomes important to know if something is a lump of dense calcium that's the same density as bone, or whether it's a soft piece of thrombus that's just going to break up and fly off down the leg as soon as you touch it with a balloon. And crucially, what we're finding with IVUS is that you don't get the full information on disease extent. I've seen angiograms that look pretty much completely normal, and then when you look on an IVUS, you can see there's a 30% rim of soft plaque all the way around it, that if you have the edge of a balloon in that plaque, is going to immediately cause a dissection at the edge and make things look worse than before. So it can be very misleading, particularly if you do angiography only in a single plane. You can really underestimate stenosis in the anterior-posterior plane, for example, if you're just doing it lateral. It would be nice to do angiograms in multiplanes as we go down, but then, of course, you get increased time, increased contrast dose. And angulation of arteries can really distort true diameter measurements. So for 20 years, well, 15 years maybe, we've had this quantitative vascular analysis based on all of our fluoroscopy systems, where you put some kind of dummy guide next to the patient's leg and use it to give the machine a number to divide the diameter by on the screen and give you a rough diameter of what to expect from the vessel. And the more and more we use IVUS and compare that with the QVA measurements of vessel diameter, particularly as a vessel goes around a bend, you can see that these measurements are just not accurate at all. One personal bugbear is that angiography can also be very misleading if you use contrast that's too dense. It really vexes me when people just take 50-50 mix of contrast saline continually, whether they're injecting here and looking here or injecting here and looking here. The density of the contrast will shadow out a lot of the intravascular detail, subtle dissection flaps, etc. But IVUS can really level the playing field in terms of showing you everything. But we'll talk a little bit about that later. Coming on to contrast, it's important to remember that maybe up to 40% of patients with peripheral arterial disease will have some degree of CKD, and crucially 25% of patients with end-stage renal failure will have clinically evident peripheral arterial disease. We've used carbon dioxide angiography for a long time. We've tried and tried and tried to make it work. It can be good with some of the newer injector equipments, but it's not great, particularly in the tibials. We constantly find that we're making technical steps to try and get the image better and still finding that we're not getting all the information that we need to deliver effective treatment. So the solution, what we've settled on, is to use angiography simply to assess speed of flow and map out the rough geography or the geometry of the vessels, the branch points, and essentially use IVUS pretty much for everything else. So quick word about IVUS physics, and I think the first thing to remember, and the thing that will help you most when you're making a transition from extravascular ultrasound to intravascular ultrasound, is to just remember it is the same ultrasound. You're just looking from a different angle. So ultrasound, very simple. You've got a transducer that sends out sound waves and measures the time it takes to return and what the intensity of the echo coming back is. And just looking from inside the vessel rather than from the outside. There are, just for a little brief diversion about physics, because this is just a bit important in terms of choosing which IVUS devices you use, there are two sort of main technical concepts, or two technical routes that you can take when generating an intravascular ultrasound image. So rotational or mechanical IVUS has a single ultrasound element of very, very high frequency that continually rotates very, very fast. And that's what makes your image. And you get a really high image resolution. And when you're pulling back, you get a nice stable orientation if the vessel is straight, because this inner IVUS ultrasound element that's rotating very fast is contained in an outer sheath, which keeps it stable. However, you can get artifact or more affected by artifact from the guide wire, speckle artifact, which I'll show you an example of later, and air bubble artifact, and something called non-uniform rotational distortion, which again I'll show you hopefully an example of later, but shouldn't be relevant for us with the Philips IVUS. I think the Boston IVUS uses this technology. I haven't used the Terumo one myself, but I think it also uses this, just looking from the quality of the image that it gets, and I'll show you an example again in a second. The Philips kit uses phased array or solid state IVUS, which is 64 transducers in a circular array. It's lower frequency, so the resolution is a bit less, but the trade-off of that is you can get much larger scan depth, which is super important for venous and actually important as we're slowly starting to use IVUS in the iliac arteries more, to be able to actually see all the way out to the edge and just beyond of the artery. It can be susceptible to ring down artifact, but it's a much more sort of stable imaging for getting sort of flow analysis with the chromaflow feature that we'll talk about later on. So for me, I find the phased array or solid state IVUS to be the better choice for peripheral arterial disease, because the resolution is enough to give you the information to make the treatment decisions that you need, and it's way, way, way more easier to use. The catheters are a lot more hardy. You can put them in and out of the patient multiple times very quickly, and the artifact is much less. So that's my personal choice. A lot of it will depend on what you have available at your center and what experience, for those of you particularly from a cardiology background, what experience you've had using for before. But for me, we prefer the Philips kit for these reasons. Image interpretation. So this is a rotating IVUS image of a coronary artery. And you can see that overall the wall is very thin, and the individual layers of the wall are very thin. So you can see this kind of blood speckle. This isn't slow flow. On a Philips IVUS you would say that this is probably slow flow, but on a rotating IVUS this is what flow looks like. And this black line here is non-uniform rotational distortion artifact as well. But what we really want to see on this image is what are the three layers. So the inner white layer that's bright is the intima. Then there'll be a black layer, which is the media, and then a white layer on the outside, which is the adventitia. So intima, black media, white adventitia, and that's the basic principle. Now moving on to a more familiar, this is a solid state or phased array IVUS. This is a picture of the Philips IVUS. I have definitely undersized this vessel, as you will all be able to point out to me, hopefully in about 24 hours' time. But we can use this image just to see a few things. So you can see in the peripheral, this is an SFA, the wall is much thicker compared to the lumen of the vessel. And those of you who are surgeons know that intuitively already from handling these arteries. This is some soft plaque in the corner over here. So sort of low intensity echo, and you can see with the phased array or solid state IVUS much clearer differentiation between flowing blood within the lumen and soft plaque, and this is why I like this type of IVUS for peripheral. This is something that you appreciate more and more of the more IVUS you do. This is called positive remodeling. This is the process that takes place in the body when your arteries start to atherosclerose, that the body will do its best to try and maintain a flow lumen out to the distal tissue that's being perfused, and will open out the artery in this size. Again, you don't get any of this information from angiography, but you can see here that even though there is, you can say, a significant soft plaque on this wall, the lumen of the artery has been maintained by this positive remodeling, and this lesion doesn't need treatment. We'll talk about that more later. Looking on this picture now, a bit further down the same artery, we can see some calcified plaque here. So again, just like you would if you're looking on ultrasound from the outside, calcium is bright white with a shadow behind it. Just because you're looking at it from a different angle doesn't mean the ultrasound properties of it change. So this is our bright white calcified plaque with dark shadowing behind it. And this is the benefit of IVUS, particularly in patients who have heavy medial calcification, that you look from the outside with ultrasound and what can you see? All you can see is the first layer of calcium, and then almost all of your ultrasound waves are bounced back, and you're looking for a window or gap between calcium where you can maybe get out a velocity measurement. But if you're looking from inside the artery, suddenly you can see much more about the plaque that's actually going to be the first thing that contacts any of the devices that you're using to treat. On this picture, you can also see a little bit of reverberation artifact, these white lines just coming behind here. And this is what we call the calcium arc. So you can again see, compared to angiography or fluoroscopy and compared to CT, you can really get an accurate measurement of the calcium arc. Reverb we'll talk a little bit about tomorrow when we look at calcium IVUS for vessel prep, helping you make good vessel prep choices in heavily calcified disease, but that's essentially what it looks like for now. Plaque morphology, it's much more simpler in the peripheral space than in coronary. We just care about differentiating thrombus soft plaque, which can be fibrous or fibrofatty, and calcification. And if there's calcium, we want to know, is it intimal, is it medial, is it both? Is it nodular or is it sheet-like? And what is the arc? Because we want to know how likely is this lesion to dissect when I inflate an angioplasty balloon across it, and if I put something with paclitaxel or sirolimus on, is the drug actually going to go into the artery wall or is it going to stay on my balloon? Virtual histology was introduced for coronary IVUS quite near the beginning actually when it came out, but it's been validated in vitro but not yet convincingly in vivo in coronary, so it's kind of disappeared from most modern IVUS machines, and really it's not that useful in peripheral. We don't really care so much about unstable plaque. Their disease is their disease. So I think the virtual histology stuff is around on some machines, but I don't find it hugely useful. This shows you an image. Same IVUS image and same histology image of the same segment of artery. And you can see again the soft plaque. You can see these small calcium nodules with a thin layer of medial calcification, particularly seen around this particular arc here, which matches there. And I'd really put that up just to show just how closely the IVUS really tells you what's going on within the wall of the artery. And for me, as a radiologist, I don't have the benefit of years of experience of holding these arteries in my hand. So for me, IVUS is like the cheat code, which tells me what I should expect to feel if I was holding that artery in my hand without actually having to get the artery out and putting it between my fingers. And that's where IVUS has made a huge game changer for me personally. IVUS can also be used for crossing, and I'll just run these two videos just to kind of demonstrate that. So this is a patient with a relatively short lesion, but with a big sort of nodule of calcium and then soft plaque at one end. And my first attempt at crossing is shown on this side. So I'm pulling the IVUS catheter back through, and if you see intima, this bright white layer, all to one side of the catheter, which is in the middle at any point, then you know that you've gone subintimal at that level. So I'll wait for it to pull through just there. You can see the intima is all on this side of the catheter there, and then there it comes back into the lumen. So I'll let that run by again so you can just watch. So intraluminal on here, and then you see the catheter moves. All the intimal layer here is all on one side of the catheter, so we're subintimal, and then we're back in the lumen. So then we did a retrograde access and crossed very easily, and then when you IVUS pull back across the same segment, you can now see that we're intraluminal all the way, and you can see the thing that forced us in subintimal when we were going antegrade was this big lump of calcium that you'll see coming up in a second just there. If you see branches, lumen, the lumen of arterial branches joining the same lumen that your catheter is in, that's a good sign that you're in true lumen. So IVUS takes away that uncertainty of are you in true lumen, are you in the subintimal space completely. It gives you a definitive answer, yes or no. And again, as we'll talk about a bit more tomorrow, when you're using certain vessel prep technologies, having that information under your belt completely changes the safety and efficacy profile of atherectomy devices. Quick look at ChromaFlow. So ChromaFlow is the name of this Doppler feature on the Philips IVUS machines. It's not a quantitative Doppler. It doesn't correlate with velocity. It has 3 sensitivity levels that you can select, but it's important to remember it's not a measurement. It can help you differentiate intima and thrombus from lumen and give you a sort of qualitative evaluation of dissections. Is the flow going underneath a dissection flap all the way around or not? You can look at malopposed stents. You can look at bifurcation lesions and assess where the true carina of the bifurcation is. And as we start using more and more sort of stenting technologies below the knee, that's going to become more and more important. You can tell the difference between thrombus in situations of slow flow. And as I said, you can look at dissections and understand how you can get a qualitative flavor of how flow limiting a dissection is. To be honest, the main reason I use ChromaFlow is to check for flow after a certain step of procedure rather than doing another DSA. So this ChromaFlow is the thing that has really saved contrast use for me, and I'll show you my workflow a little bit later about how it's done that. That you can just flick it on at any moment, see that you've got pulsatile flow, you don't need to do a run, move on to the next wait till the end of your procedure, and then finally do a run. Quick word on dissections. IVUS shows it in excellent detail, maybe too much detail. This was the sort of A to F angiographic dissection classification that was around for many, many years. But again, as soon as you start to see it on IVUS, you realize that most of these aren't representative of what's really happening in the artery. IVUS shows you in great detail, maybe too much detail. One of the criticisms of IVUS is that it leads to too much stenting. And what we do need to do is to refine ourselves over the next few years about how to take all this information that IVUS gives you about dissections and translate it into good clinical decisions. This I-dissection classification was developed, which gives you a letter for the deepest layer, so A for intima, B for media, C for adventitia, as in how deep does the dissection go. If it goes just into the intima, it's an A. If it goes all the way through the adventitia, it's C. And then a number 1 or 2 for if it's less than or more than 180-degree arc. This has not yet been validated in terms of the classification, but what we do know is that injury to the media of an artery correlates with restenosis. So I don't run every dissection that I see through this classification, but if I can see it penetrating through to the media, and particularly if it extends more than 180 degrees around the arc of the vessel, I'm going to take that much more seriously than a limited intimal dissection. Finally, a quick word on artifacts in IVUS imaging. So with the set phased array or solid state IVUS that Philips use, the main artifact will be ring down artifact. So I'll let this loop play around and round and try and catch all these artifacts as they come through. So ring down is where you get these bright halos surrounding the catheter. So just there, you can see just there's a little bit of line briefly at the beginning of that loop, and that's just oscillations within the transducer crystal, and it can create a bit of a zone of uncertainty if that little bright bit is sitting exactly over the detail of the artery bit you want to see. So I'll just let that come around again and point it out. So we're coming down to the end of the loop, back to the beginning. There, those little lines are the ring down. Very easy to get rid of. There's a button that says ring down. You just move the IVUS catheter to the largest artery that you can access it to, so the catheter sitting in the middle of the lumen, press the ring down button and it will go away and you can carry on to use it. Shadowing, we talked about, is what you see behind calcium. It can also, air bubbles can also cause shadowing, and stent struts can also cause shadowing. So anything that's extremely dense where the sound waves are going to bounce off it, you're going to get a shadow behind it. Calcium, obviously, you can't really do much about initially unless you're actually treating it, but for air bubbles you can always flush through with saline, clear the air bubble, move the leg, change the position of the air so that you can see. Stent struts, again, you can't really do too much about it, but again, if you can see a stent strut separated from the arterial wall, that gives you a target to treat. Sheath artifact, you'll see at the end of this, you can see through a sheath with IVUS. So there's the IVUS now in the sheath. You can see a double layer of the sheath wall, but you can still get a perfectly adequate assessment of the vessel around the sheath, as you can see on there. I'll just let that run around again into the sheath, but you can still see the tightly stenosing calcium there. Reverb artifact gives you this kind of further impressions of the same structure multiple distances from the transducer, so lines in a geometric pattern behind an area of shadowing. Calcium, stent metal can cause that. And then finally, you can get this, it's not really an artifact, but I put it here as a sort of other thing that you can see. In peripherals, if you see the catheter starting to knock, this kind of, with every systolic beat, you kind of feel like it's hitting against something. With the picture that you get a sort of dunk, dunk, dunk like this. In coronary, that's just systole because you're right next to the heart. In peripheral, usually it means that you've got distal spasm and the catheter will start knocking. You can't feel it knock, but you can sort of see it on the screen. So if you start to see that happen, immediately check your distal circulation because you've probably got spasm. We won't talk about blood spectrum and non-uniform rotational distortion because they're not a feature with Philips IVUS. So I won't talk too much about this because this is what the other speakers are going to mention about, but essentially, these are my pretty much 5 steps that I do for every patient or think about doing for every patient that we're treating. We cross, we prepare the lesion if it's appropriate to do so, we treat with an angioplasty balloon, we may scaffold, and then we do something to stop it narrowing up again so soon. Basic schema. At each stage, there are things that IVUS can do to help you optimize each stage. And I said I'm not going to talk too much, but just keep in mind in your head as everyone shows you cases, which step of those stage people are using the IVUS in and where they're finding it useful, and maybe that's where you will also be able to find it useful in your practice. In my workflow, everyone develops their own way of using it. We will eventually get to a point where the IVUS imaging is completely matched with the fluoroscopic imaging, and you can scroll through you can scroll up and down the leg in a fluoro loop and see the IVUS image of that slice next to it. That will happen at some point, but it's not here yet, so we have to figure out to work how we can without that. In the coronary circulation, they put the IVUS catheter is connected to a small motor. They call it a sled, and you press the button on the motor, and it will drag the IVUS catheter back at a particular speed for a particular distance, and then it's much easier to go back and see. Unfortunately, for most peripheral work, all of these sleds are way, way too short, so we have to do something else. What I tend to do is use fluorograbs or single exposures, whatever your C-arm can auto-map back to mark the position of any point of interest that I'm going to use to guide future treatment. So a tight lesion is here, fluorograb with the IVUS in that position, or a single digital image with the IVUS in that position, and tell our techs in the room to record what I'm seeing at that point, or I record it myself on the IVUS on the IVUS machine itself. Now that we've got the touchpads that we can use very close to us, and just get into habits early of labeling your images as you go. We didn't do this for about 5 years of deep venous work at St Thomas's, and I'm sure there is a whole treasure trove of information in there that we will never know what it means because none of the images had labels on. So please get into a habit of labeling. With the new touchscreens, there is no excuse. It takes 10 seconds at the end of every pullback. So this is what we do. We do a preliminary DSA with dilute contrast just to get the geography. We'll cross, do an IVUS pullback for documentation, measure the lesions on IVUS, mark them with fluoroscopy, as I've said, measure reference vessel diameters, proximal and distal landing zones for both for balloons, because we can see that diffuse disease and understand which bit of the vessel is truly healthy, we can make sure that not only are we stenting healthy to healthy, but we also balloon healthy to healthy, which will reduce your incidence of dissections. Then we do our angioplasty, check the chroma flow, put that qualitative Doppler on to make sure the flow is still running, do another IVUS, and look detailed into that to see, is there any areas where we need a touch-up angioplasty? Is there a dissection that needs a repair? If we don't need any stents, and if we're looking intraluminal, DCB. If we need a stent, we stent. Final IVUS, and then only when we're happy with the IVUS do we do a final DSA to document the flow. This workflow will look very familiar to all those of you who started using IVUS for venous work, because this is exactly what we do for venous. I've not invented anything here. It's literally just taken the same workflow and applied it in arterial. But the patients are so much more vulnerable in arterial, right, from increased contrast load. So that's where it really becomes useful. So, very quick word about indications. These are just mine. Again, every speaker will tell you theirs, and there'll be a lot of the same flavor and some that are a little bit different. I see it as spending a little to save a lot. If I'm going to use a vessel prep device, these devices are not cheap. I want to know that if I'm using it, that I'm using it in a patient that's really going to benefit from it. If I'm using it, I also want to use the right size and the right device. And if I'm going to use DCBs, I don't want to waste money by undersizing them, because a drug-coated balloon that doesn't touch the wall of the artery is a complete waste of money. Even if you don't use vessel prep devices, you'll optimize your angioplasty technique with accurate sizing, healthy to healthy, and if you stent, you'll have well-sized and accurately positioned stents. And CLTI, particularly with tibial disease, which Mark is going to talk more about, opening what he's talked about, target arterial path, we're going to see more and more of this over the next year. The Basel II guys and the best CLI guys are currently going through all their angiograms to define GLASS classification, target arterial path, and we're hopefully going to be getting that data really granularized, and this idea of direct inline flow to the wound is becoming more and more popular, and IVUS will help you do that. You increase the durability of your revascularization and hopefully get faster wound healing. Thank you very much. So Mark, do you want to come back up? And now Mark's going to take it a bit more clinical and get away from the theory, but hopefully that's, now you know what the pictures mean.
So NT, I think it's a really good time for questions as well from the audience. Anyone have any burning questions or any questions now before Mark starts? So I've got one for you, NT. So if you were to start using IVUS in your practice, what vessel bed would you aim to use it for as a early use beginner?
I think that depends on where you're coming from. I used to just straight away say FemPop for this, but now, having seen the journey that so many people have had before they've started using IVUS in peripheral, If you're confident using it in venous disease, then it means that your kind of idea of the steps and the workflow and handling the machine, you're probably already there. And I would say you can start using it anywhere. I wouldn't say one territory or more. I think if you've used it mostly in arterial disease before, probably FemPop is where it's a safe space to learn, because it's much easier to interpret. The crossing is usually easier. And you can devote most of your brain work on understanding plaque differentials, and the vessels are big enough that you can actually accurately assess plaque as a beginner and see the difference between calcium, soft plaque, thrombus, etc. So I say if you're coming at it from being completely new to IVUS, probably FemPop, but if you've got lots of venous experience, go anywhere.
And on that note, can you give us a rundown of the different types of catheters there are in terms of the sizing, rapid exchange over the wire? Because the aortic, I think, might be using 035, etc. So can you give us a summary of what's available?
So 014, 018 platform, both of those, I believe, are rapid exchange. And then there's the over-the-wire 035, which is the one that is more useful for aortic work. I tend to stick with the 014, simply to make it easier for my stockroom guys to reorder, and also because a lot of the other devices that we use will go over an 014 wire. So just to minimize wire exchanges during the case, I tend to stick with 014. Some people find the 018 useful, me less so. Definitely for aortic, the 035 is much more helpful to get the field of view.
And the other really common question is wire. What wire can you use over an 014 IVUS?
Anything. I mean, again, the choice of wire will normally be dictated by minimizing the number of wire exchanges during the procedure. So it will go over, if it's 014, it will go over any 014 wire.
Any other questions? Yeah.
Yeah, you talk a lot about the selecting the proper equipment for vessel prep and also sizing. In our service, most of the times we have CTA done previously, so we lean on to that a lot when we make decisions about sizing and what kind of equipment we use. So if you take that into account, what are the main benefits of the IVUS in these cases?
So we were in the same place, that we are very CTA heavy. Most patients, if they've got the renal function to do it and the time to get a CTA before we proceed to revasc, will have a CTA. And that's fine, definitely for iliacs, good for sizing. FemPop, tibials gets a bit more tricky, but can be used also. I think in the setting of heavy calcium, especially big nodules of calcium, it can be difficult to size on CTA. You have an idea of what the reference vessel diameter may be from a healthy segment close by, if you have one. But if you have diffuse disease all the way down the FemPop segment, often it's difficult to find a segment to say, okay, I can put my calipers here and be confident that this is really the size. So I think in the setting of heavy calcium, we were finding that CT was underrepresenting. And when your tools were just a balloon, and then maybe a bailout stent, maybe that was fine. But when you have things like Shockwave that you can use, actually the sizing becomes a lot more important. Knowing the real size becomes important. Then with the tibials, we were finding that often, especially if the patient has circumferential disease, working out the exact size is again a little bit more tricky. Unfortunately, I don't have access to the raw images done by our duplex scanners. We just get a report of percentage stenosis and barely even velocity sometimes. So without access to that tibial sizing, we found quite tricky. As we start to use more drug-eluting stents in the tibial circulation, again, the sizing has started to become more important. So that's where we found it had added value. I don't use IVUS for every case. I use it for about half of my cases. And I try and use it in the cases where it's going to give me a bit of information that the imaging we have already may be misinterpreted or may not be completely accurate.
So we've intentionally left loads of space in the programme for this afternoon for any burning questions. So please do ask any questions you have. I can ask you one more about trackability. Have you had any problems tracking the IVUS catheter, and what are your strategies for when you have those problems?
So the 014 catheter started out for coronary, so it is very, very trackable. It is designed to go through tight anatomies in coronary lesions. What I will say, where I have occasionally been caught out before, is by trying to push it too hard through very focal, heavily calcified stenosis. And it's happened to me twice, and the first time it happened, I pushed trying to get the IVUS catheter through a really, really, really tight lesion. And I pushed too hard. And as soon as it went through, sometimes you've just done something wrong. Pushed too hard, felt something was wrong, did an angio, and I'd actually managed to embolize a small piece of that plaque by essentially dotarizing it down. So now I have a bit more of a feel with experience of how hard to push. And if it won't get through, a 2 millimeter balloon angioplasty just of that lesion will then help the 014 IVUS catheter get through. So I don't have to predilate very often, but now with some experience, I have an idea of the amount of force is too much. And a 2 millimeter predilation, as I said, is more than enough.
I mean, I've had the same problem, but actually what happened to me is I broke the IVUS catheter. What happened is using the rapid exchange, what happens is I actually get a lot less push anyway, inherently. I think that's probably where I'd want to use the platinum ST equivalent. But yeah, definitely I've broken a few catheters by pushing too hard in exactly the same situations.
Yeah, so I've got a bad reputation of being called the IVUS slayer because I've pushed too many catheters down. I think that's what William calls me sometimes. So I think that's a really good point to predilate if you need to. Mark, I noticed that you've got a great setup, even though you've got a very small space. Yeah. Can you give us an insight into how you worked out where to put the IVUS, the machine, and then your touch screen, and what works, what doesn't work?
So it's all about, I think, our visibility as the operator. So first and foremost, it's about our ergonomics as anything else. We need to be able to see it. And this is where the touchpad really helped with that. It wasn't just about my ability to be able to drive it, measure RVD, be able to record the pullbacks, all these things that we want to be able to do without relying on somebody that's outside of our operating field to do it for us. But the thing that I would say is that the transducer that actually is separate from the machine is ever so important to bring as close as possible, particularly as I'm using, and I tend to use the 018 actually, because I just thought the image quality was better. But if we're taking and I'm using a 6-French sheath anyway for the majority of what we're doing, so that didn't really add too much to me. But if you're taking that catheter all the way down the tibials, then that can actually be quite a lot of working length. And actually, the catheter itself can be restricted by how much slack you've got on that. So it was really a case of doing it once, thinking, hang on a minute, we need to move this a little bit closer. So that trial and error took a few cases to be able to perfect, whilst maintaining as much sterility as possible. But ultimately what we don't want is other people to have to do anything. We want to be able to do that ourselves. And as I say, with our relatively new, had it about 6 months, machine, that has really sped the process up because it's enabled us as the operator to be able, do you find the same? It enables us to be able to take control of it. Yeah.
Basically, we're all control freaks. But to that point about going distally, one tip I always give to our nurses when we're setting up is don't connect it yet. Wait. Get the IVUS into the body, take it as distal as you think you're probably going to need to take it, and then connect it. And then it will get that far, and everything else coming back is easy. So when you're setting up and using for the first time,
pulling everything towards yourself.
Dragging everything slowly towards you as you go more and more distal.
Definitely done that.
And how far distal can you go? Or have you been?
DP, lateral plantar.
Yeah, into the foot.
Yeah, well into the foot.
And the other thing I noticed is quite often in NT, on your cases, if you have an assistant, you take the wire out of the IVUS. Can you give some more information about that?
So this is, again, anybody who's got a coronary background will be more familiar with this. With peripheral, those people who've trained in vascular surgery and IR tend to be more about putting devices over wires. In coronary, when you're doing PCI, because you learn so much how to be a essentially independent operator with a nurse standing on the opposite side of the trolley from you, you get into this thing of, rather than putting a device over a wire and taking a device off a wire, you kind of pluck the wire out of the device, spool it in your hand and loop it and hold it, and then put the device down and put your next one on without really moving your feet or barely turning your body. And when you start to use more and more of these extra equipments, IVUS, vessel prep devices, having the ability to do that, it just increases your hand skills more because you just get a better tactile feedback for quickly exchanging wires, and it just makes the whole process a little bit more smooth. So rather than walking everything back off three meters of wire, you can just kind of take a loop in your hand and get devices in and out very quickly. And that's one of the areas where I think that you get that initial slightly slower when you start to use IVUS, and then suddenly you speed up once you get that skill. And then once you start making all your decision making right at the beginning of the case based on your first IVUS pullback, then you actually start, I've found, to get faster. So now with IVUS, because I'm doing less kind of angiogram, think, look around the room, look at the clock, look at the foot, look back at the angiogram, and make a decision. I've pretty much made the decisions about what we're going to do as first-line treatment and what the bailouts are going to be if each of those treatments are not successful from the first IVUS pullback, and then the speed really goes up.
Biggest thing I would say is I sometimes forget to record a loop. So I do it all and think, oh, okay, get the information I want, and I haven't recorded it for posterity. So yeah, you'll see that tomorrow with some of the cases. Don't always have a completion loop on them. But yeah, the other thing to mention from what I said is that the catheters that we tend to use are the rapid exchange ones. So you can't actually pull the wire out. So it's more about, I guess, controlling it as you put going forward. Right, so...
Do you want a laser?
Oh, thank you. Time for part two. A lot of this, I think, NT would have covered far more eloquently than me, but we'll start really, you know now what you're looking at, okay, from NT's talk. I don't need to go through this again. Catheter-based, militarized ultrasound machine using a piezoelectric transducer. What can we learn from cardiology? Well, it turns out that actually cardiology have been using endoluminal imaging, I think, far more widespread than we have in the peripheries. Whether you're talking about IVUS, OCT, or otherwise, they do tend to use this a lot more than us. Are they better funded? Are they more interested? Well, the answer is probably. But what can we learn from them? So this is a 5-year outcomes of a study that compared the use of IVUS-guided deployment of a drug-eluting stent versus angiographic guidance. 700 patients in each arm out to 5 years. And what you see is that there is a difference, a significant difference with the, and this is, I believe, major adverse cardiac events is the endpoint here, significantly less in the IVUS group, and this difference is greater out at 5 years. So the longevity of your decision making, in the coronaries at least, persists beyond 5 years, okay? So can we extrapolate that to our peripheral experience? The answer is why not, okay? So we'll talk about where it might fit in and what kind of workflows. And again, NT touched on this. I learned this and it stood me in good stead, and I want to teach you as I learned it, probably from what I heard from NT and Ash teaching in the past. And it's about what information we can get at each stage of our procedure. And I'll go into this in just a slightly different way. So if you're thinking about the pre-treatment evaluation, we can accurately size the vessel and the length of the lesion. So we call that reference vessel diameter, don't we? You can look at the morphology of the plaque. Again, NT went into that, and I think we'll be looking at that in more detail tomorrow morning. You can look at more qualitative data, as in where is your wire? Is it in the subintimal space? Is it in the lumen? Does that then guide your choice of vessel prep? Well, it certainly should. Reducing contrast in the way NT's already described. Then there is the ability for us to post-treatment evaluation. So actually, how successful have we been in both gaining lumen and in any subsequent adjunctive procedures required, whether this is bailout stents, whether this is re-ballooning, or whether this is, if we are planning a scaffold from the get-go, how well is it deployed and opposed to the vessel wall? But again, is it sized correctly? This is particularly true of those stents, I suspect, that require one-to-one sizing, like the Superior or otherwise. Have we gained lumen? That is the point. That's why we're there. Have we achieved it? And in which case, do we need to do anything else to maximize the benefit from our procedure? Now, this is something that I saw about a year ago. Has anyone else seen this? This was, I thought, a wonderful way of representing this, and this was produced from our friends in the image-guided therapy team at Philips. And this really kind of summarizes what I've just told you. So in the pre-intervention phase, it's about the lesion and about whether you've crossed it. It's about where is the wire. It's about what is the RVD. Then there is the selection of vessel preparation, and then this is, of course, where other devices within the Philips product range come into it, whether it's laser or atherectomy or specialist balloons. And then, has the vessel preparation been sufficient? Then, of course, our definitive treatment, whether that is drug-eluting stents, drug-coated balloons, or other stents. and then how well have they been deployed. So this is a workflow with which we're probably all instinctively using, but this really goes to show that IVUS has a utility in every step of that workflow in giving you that information that I've already alluded to. And we'll talk about this in a little bit more detail now. I'm sorry to disappoint you. The promise was of something a little bit more clinical. This is a little bit more theory. I'm ever so sorry. But when we're thinking about RVD, so we're comparing in this retrospective study RVD estimation from angiography alone versus that accurately measured through IVUS. And the results were, I'm sure you've all heard this, very much that IVUS demonstrates the vessels are at least 1 millimeter bigger than you think from this particular study. However, why don't you then just add 1 millimeter to every balloon you select off the basis of your angiography? Well, the truth is that the randomized control, single center randomized control trial, I'll talk about briefly in a minute, actually showed that 11% overestimated the balloon size. Overestimated the reference vessel diameter, sorry. So you're actually oversizing the balloon relative to the vessel. And think about how damaging that might be in the tibials, for instance. Likewise, there was a difference in nearly 50% of the patients of more than 1 millimeter. So we're hopelessly guessing at the true reference vessel diameter by using angiography. And these sort of situations that led to this huge disparity were things such as small vessels, CTOs, calcification, stents. These are all that CLTI population with which I'm, again, tenuously linking to this talk. So why is it important to get a true reference vessel diameter? Coming back to your point from CT, well, it's because you can oversize your balloon just as easily, I suspect. In the tibials, this is more important and cause irreversible damage. Getting the right size drug-coated balloon so that it isn't just flapping in the wind, washing the drug off to your distal circulation and being delivered to the vessel wall where it's needed. Those states that we're talking about, the CLTI populations associated with those predictive factors that render angiographic estimation of RVD that much more difficult, such as CTOs and long lesions. And of course, then again mentioned, IVL requiring a 1 to 1.1 or 1.2% oversize. What about calcification? I think this is kind of where I wanted to come in with your question about using CT as a way of evaluating pre-op RVD. Thinking about a comparison between the imaging modalities we frequently use, such as PACS part classifications are angiographic, of course, you know that. Finelli CT, based on the quadrant idea of calcium. When this was compared to an IVUS gold standard, what we saw was a sensitivity of the angiographic calcium scores of around 66%. And this is in identifying severe calcium. CT fared even worse. That was more like 30%. So what we can understand from this study is that conventional non-IVUS imaging modalities drastically underestimate the severity of calcium burden. But why is that relevant? So what is it about vessel wall calcification that we need to be cautious about in our CLTI patients? So the great Fujihara, I actually met him last week. It was a bit like a fanboy when I met him. Estimating pre- and post-treatment assessment of calcification and then the outcomes from that. So it's a retrospective study again. So no calcification of less than 180 degrees, which we'll talk about more as we go on the course. 180 degrees is a differentiation, I guess, between mild, moderate, and severe calcification. It would not surprise you to hear that minimal luminal area was less in the area, in the group, minimal luminal area achieved was less in those patients with severe calcification relative to no calcification. So basically, the aim of the game is to gain lumen, and you did it less successfully in those situations with heavy calcium. So far, not a surprise, right? Likewise, when deploying a stent, the rate of male deployment of the stent was significantly greater in heavy calcium. So far, less lumen and less accurate stenting in the heavy calcification group. If you think about this in terms of restenosis, there was significantly greater in the calcified groups relative to no calcification, but in this study it did not lead to further re-interventions. So to ram that point home, severe calcification is underestimated on our non-IVUS conventional imaging modalities. We know that CLTI disease states are associated with a greater burden of medial intimal wall calcification. These very populations we're talking about. Severe calcification is associated with worse outcomes, both in reduced lumen gain and in an increase in restenosis, but in that study at least, not reintervention. And it helps us to understand the true reference vessel diameter and the burden of calcium when selecting which modality to vessel prep we are going to go for and what size. Virtual histology was mentioned. It's not validated for using the peripheries, but I can't imagine it's far away with the developments and advances in artificial intelligence augmentation. Will it help? I don't know. I mean, you seem to think quite clearly it wouldn't. I don't know, NT. I wonder whether or not it might help us to decide which vessel prep or none at all. It might help us to try and sort of validate that against outcome a little bit more. I don't know yet, really. But the point is, hopefully, it will be possible. And then, of course, where in the vessel are you? And why is this important? Well, we associated larger number of CTOs in the CLTI populations, areas where we re-enter the lumen. Are we going to necessarily be using the atherectomy devices in these areas? Well, the answer is often they are contraindicated in subintimal passages. So it's important to know where you are, isn't it? And will that guide your choice of vessel prep? I suspect it might. Then there is the post-procedure evaluation and dissections. Why is this important? Well, we know dissections, particularly those of a greater than 64 degree of the circumference of the vessel, are associated with a higher risk of restenosis. Studies comparing the detection of dissections versus plain angiography, 3 to 6 times greater detection. And as NT said, sometimes this can be a little bit too sensitive and lead us to perhaps be a little bit too aggressive. But the fact is, until we really know, validated against our eye dissection classification, it's possible that we're going to undertreat and overtreat, depending on what our evaluation method is. I've just put this up for the sake of completeness. NT's explained that far better than I will. What is clear is IVUS does detect more dissections, and they are more severe than angiography. It also detects, this is in the randomized controlled trial that I mentioned, residual stenosis that would missed on angiography and inadequate stent deployment. The eye dissection classification is very much to do with the arc of dissections, and we know that even at smaller degrees, these are clinically associated with greater incidence of restenosis and potentially then re-intervention. I'm going to very quickly talk about a case. Do you remember I told you about our typical CITI population? Doesn't matter where you are in the world, they all pretty much look the same. And this lady, despite being quite young, has got pretty much the full ticket of comorbidities, and to boot, she's pre-dialysis as well. Preoperative duplex demonstrated a flush SFA occlusion. She has a wound. She is a Rutherford 5. CO2 angiography, well, it was okay. As you said, NT, it's okay. But what I actually did was, I'm not sure you can really see it here, was put a radio-opaque ruler underneath her leg to enable us to co-register the positions of the lesions, the length of the lesions, and to record them. You see it a little bit better there. And this is us putting our IVUS catheter down, and we would measure, for instance, somewhere that was at 290 centimeters. And that enabled us to then co-register where the lesions are. So far less low tech, but it worked. I didn't actually do this on an unsterile leg. I did it so that I could get a photo and show you the idea. Actually, what I tend to do is to do it on the drape, overline the leg. It's where I tend to mark it. And that seems to help, if anything, just to know what the numbers are. But you can see the radio-opaque ruler and how that might fit in underneath the mattress. So here was my vessel preparation. That was really just to show you that I was subintimal at the area in and around where this stenosis was in the adductor canal. So my choice of vessel prep there was IVL because of me being very clearly subintimal, both at that heavy area of calcification and at the top on the basis of my IVUS guidance. What happens when you inject CO2? Ouch, it hurts, and they move. So that really wasn't helpful. All it was really useful for was for flow. But having deployed the IVUS, I was able to see that I had got insufficient lumen gain at 2 areas of that IVUS pullback, which enabled me to go back and post-dilate, even despite having used a DCB first time round. And actually, the result was much better. So this is one of the dissections that was left behind the knee as a result of my post-dilation. Everyone have a guess of what that classification would be? Go on, have a guess. It's either a 1A, a 1B, a 2A, 2B, I would say. What do you think? Huh? Think 2B? I made that a 1A. I thought that was less than 180. It was about just less than 180 degrees and into the intima. So I actually left that. But as NT said, there isn't actually a validated way of us being able to ascertain what the outcome is as a result of this classification. And until we get that, it's going to be useful only in descriptive rather than predictive terms. Right, so this is the randomized controlled trial that was done a couple of years, it was published a couple of years ago, and it was looking specifically at the FEMPOP area, and it was incorporating both claudicants and CLTI patients. The outcomes were freedom from binary restenosis, so that's either is there restenosis or not, and this was ascertained through duplex at 12 months. The results were, this was the pre-treatment groups, and around 45% of these patients were CLTI. So it's relevant to this talk, I hope. Outcomes at 1 year were significantly reduced binary restenosis at 1 year in the IVUS group versus the angiography group alone, but this did not translate into more reinterventions. What they also found was that the choice of DCB was greater in the IVUS group, and I think really importantly, 80% of cases that were in the IVUS group resulted in a change in your management. It changed your decision making in the overwhelming majority of cases. The particular disagreements between the two modalities were in terms of the RVD and the length of the lesion. These are two things that we've established, and hopefully I've convinced you are essential to the successful outcome. A question was posed then, is this improvement in 1 year freedom from restenosis related to a better choice of DCB size? Well, if it is, then surely that in itself is an important outcome. Wouldn't you agree? There has subsequently been this was sort of early results, 1 year results of another RCT, this time multi-centered from Korea. And this was looking at IVUS-guided DCB versus angio-guided DCB. I'll be a bit quicker now. And this was a straightforward one-to-one randomization in either group. There was a small amount of crossover. And the endpoint of this was particularly primary patency, but that was defined as freedom from clinically driven TLR. Right, so again, we're looking at about 25% of patients here are CLTI. Not enough patients really for subgroup analysis, but still they are at least included within this study. And you can see that comparison between IVUS and angiography group, greater degree of technical success. Procedural success was different in that it was freedom from complications as well as just less than 30-degree residual stenosis, which was defined as technical success. And then the clinical endpoint was post-procedure ABI and Rutherford category. At 12 months, they favoured IVUS group with respect to primary patency and freedom from TLR. So unlike the Allen paper, this paper demonstrated an improvement in, or rather a reduction in the reinterventions in the IVUS group. You can see that represented here. This is the primary patency analysis at 1 year. And the freedom from TLR was both significant. Now, this is, again, a very important take-home message because it starts to, I'm starting to wrap this up now, guys, you'll be pleased to hear. It starts to beg the question is when should we use IVUS? NT said he uses it in about 50% of cases. I think it's probably fair to say we're about the same at the Royal Free as well. But the question is not how often, it's when, isn't it? It's when should I use it? When are the cases that will benefit from it the most? Well, in this particular study, the benefit in terms of primary patency was greater in the more complex anatomical lesions. sort of makes sense, doesn't it? And I think instinctively, if I know that I've got a more complex anatomical basis, I would probably use IVUS rather than those where I know it is less complex, or I have more confidence in the duplex. So in conclusion for this particular study, it's improved the outcomes of the DCB angioplasty in the FEMPOP in both primary patency and in freedom from clinically driven target lesion vascularization. And this was definitely true of the more complex FEMPOP lesions. I've recently been part of a consensus group in vessel preparation, and what was really interesting was, I was telling Warren and Ali about this, was that when we were talking about how you evaluate lesion morphology and therefore decide on what and how you are going to prepare the vessel, it was almost universally accepted that we would use IVUS as the gold standard. Now that's really quite a departure from what I'd been hearing for the previous few years, where IVUS adoption, particularly outside of Japan and the US, is relatively slow and certainly lags behind that of cardiology. But if we think about the sort of information that we can get from IVUS that we can't get from angiography, I think that's really quite an important comparison. And I'm not sure if you guys have ever thought about this before. So certainly when it comes to things like plaque morphology, I would argue that aside from calcium and the fact that there is a filling defect, CT won't give you that information either. Okay? Position of the wire, the thrombus, dissection certainly less reliable. The only metric with which I think you could possibly criticize is with flow, and when it's done in conjunction with angiography, that is how I think we overcome that and it becomes the best of both worlds. And again, if you're thinking of how would I use IVUS or where would I use it within my practice, this consensus document from which that table before was taken, the majority of the consensus within this, this was American-led, I think, consensus paper, was that the utility was probably greater in the tibial vessels. Now, don't know if that's the same in your practice, but I would agree that's probably starting to become more true for us too. Although that said, I think we all still use it throughout, don't we? Even the iliac arteries, as I say, definitely useful for it, but you can certainly make a case for the more complex below-the-knee disease. And finally, my final slide then is really to say, what is it that we can expect from you guys here at the end of a certain period of time and transition from novice to experienced? Well, that I think is an important slide with which to set your own benchmark. So have a good look. But by the time we are finished this weekend, finished this week, certainly hope you'll be able to accurately size the vessel, to understand the basis of the lesion morphology, and to assess recoil, dissection, and the need for further adjunctive intervention. Okay? In conclusion then, it's all right, I saw I got a minute left. In conclusion then, we're dealing with the worst of the worst in terms of our patient populations. We're dealing with complex procedures on complex patients. We have to do them quickly, we have to do them effectively, and we have to do them once. Our interventions, although potentially more expensive initially, need to be done conclusively, okay? And this is why I think you can justify the use of IVUS, because it helps me make better decisions. Its benefit is across the utility of our workflow in the pre-intervention evaluation, in the choice of modality for vessel prep, and in the subsequent evaluation of our procedural success. In the randomized controlled trial of Allen in 2022, it changed the treatment choice in 80, or rather the treatment plan in 80% of the cases. So it definitely has an effect on your decision making. And hopefully in detecting those things that are difficult to, if not invisible, for conventional angiography. Thank you very much.
So that was a great start to the workshop. So you've heard about the rationale, the evidence behind IVUS, and the basics. So the next few days will all be hands-on, case-based interpretation and trying to understand where and when IVUS is used. So we've got 2 minutes for questions, and then we're going to have tea and coffee. So any questions at all, or did everyone just want coffee? Conrad.
Just a comment. I think it's a really good point, that dissection, whether it's a stent or not. One thing that we still don't have is that longitudinal assessment. And when you look at these static images, actually on the side there is that kind of virtual angiogram, which you can then have against your angiogram. So if that was a curtain which extended 2-3 centimetres, you'd be far more keen to the stent. And that's the main criticism, I think, of the eye classification. And that's the next paradigm in IVUS, is the Z-axis or whatever axis there.
Any other questions?
I have a basic question. Does it work in the case when you have no antegrade flow, in the case of performing open surgery in the groin maybe, when you perform your endo procedure during the clamping time of the superficial femoral artery? Can I use IVUS in this case for the femoral artery when there is no antegrade flow?
So the answer is absolutely yes. So we often do hybrid procedures where we do endarterectomies, pop a sheath down, and then we do our SFA interventions. You're assessing morphology, vessel size. The one thing that you'll see from the next few days is IVUS. We don't use IVUS to assess flow at the moment. They have chroma flow. There is some technology there, but I don't think they quite, and even Philips, quite understand what we're seeing with chroma flow. But I'll show you some cases where we are using chroma flow. But absolutely, when the groin is open and you have a sheath down, certainly you can use IVUS.
Caveat to that will be, assuming that you have liquid around the catheter. Because if for whatever reason that you're in an exposed area of the vessel and there is air, it will not conduct the ultrasound.
Okay. And there is no influence to the image quality?
No, not at all.
Okay, perfect.
Sort of like OCT where you need to flush with contrast.
Yes.
Okay, let's have tea and coffee and some cake, and then I will see you in about half an hour's time. If you can all go out the door and go to the right, I think that's where the refreshments are. Thanks, everyone. Okay, shall we continue? I hope you're well refreshed. So the next session is going to be some more practical case examples. So please feel free to interrupt, ask questions. This is a very interactive session. This is about how to assess the vessel during your cases. And we'll go. So what happened there? That's not right. So let me just go back. Apologies. It's like controlling that's what's controlling me. So what's it doing? See what I mean? Let's just try that one more time. Just played it earlier on, it was fine. Okay, we'll try that one more time. No. Yeah.
Press the button, NT.
Hello. Very good. Right. Well, actually just sorting it out, it's a little bit talking about the two trials that Mark mentioned. And just a little confession that my reason for wanting to do this is not just because of my deep commitment to education in peripheral vascular across the world. It's because actually I think the real area where we're going to be able to show the benefit of using IVUS is in CLTI, because that's where you see real hard outcomes earlier on. Those two trials that we talked about were more than half claudicants in one and 2/3 claudicants in the other. And I think to see the difference between IVUS use and not IVUS use in claudicants, you're going to need longer follow-up. Whereas in CLTI, hopefully we should be able to get harder limb outcomes very early on. So the aim is to try and get enough people interested in using it and trained up to a certain standard that we have enough centers that at some point we can run an IVUS RCT in CLTI patients and really uncover the difference. So yeah, that's the secret reason behind doing all of this, is that we have loads of centers across Europe and the world who could run a trial like that, where you have somebody blinded to the IVUS images who does the treatment in half the patients and somebody who has access to them in the other half. Good. With that in mind.
Let's try it again. So, as Mark already mentioned, so we use imaging a lot in elite sport. Okay, be it football. Mark, that is your beloved West Ham losing there. We use it in elite cricket, tennis, and I would say that sport has changed for the better. Using this imaging technology. And you've seen this workflow throughout. You've seen NT talk about this, so you've seen Mark mention it. But I want to reiterate, I haven't conferred with Mark or NT about my slides, but actually we've come up with the same kind of process. So what do we do and how do we use IVUS? So I use IVUS before I decide on my intervention. So I'm using IVUS to determine where is my wire. Is it in the lumen or is it out or is it subintimal? I'm looking at the plaque morphology, the vessel morphology, to determine, am I going to vessel prep? Is this simply a stenting case? And is it calcified? And where are the potential areas where I might have a dissection or a problem? And then, of course, everyone talks about sizing. What is the size of the vessel? But it isn't all just about the sizing for IVUS as you do more and more of these cases. At that point, you do your intervention using your appropriate vessel preparation if you're doing vessel prep, and then you're planning as well for bailout devices based on your original pullback. So you have a vessel size, you know what stent you're going to use if you have a dissection. You're not thinking, well, what should I use, a 7 or an 8? You already know in your head what you're going to use. And after your treatment, you think, I'm done here. Before you do an angiogram, do an IVUS pullback to decide, am I done here? Is there anything else I need to do? Or can I do my final angiogram because I believe that I'm done? And the angiogram is just to look at flow. It's not to confirm that you now have luminal gain and that you haven't got any technical problems on table. So IVUS can be used to look for stenosis. You draw your lumen, your actual vessel lumen, and then you draw your current lumen, and it gives you a percentage there and then. You get an objective value straight away. You can assess straight away for dissections, and you've heard about that all afternoon. And also, you can determine whether your stent is undersized or well opposed. But if you've used IVUS, then you won't need to. You should already have a well opposed stent. So wire positions, really important for vessel preppers. Identify the lesions that are high risk, the eccentric lesions that are likely to dissect to determine what vessel preparation you might use. And the aim here is to reduce plaque burden. If you can reduce plaque burden, it means you can treat a vessel with less barotrauma, less risk of dissection. Increasing vessel compliance, so especially for tibials, for example, using intravascular lithotripsy or other devices, you have an idea that if I can improve my vessel compliance because it's very calcified, I'm likely to achieve luminal gain. And all of that is without barotrauma, because we know barotrauma is linked to restenosis. And then vessel sizing is key because we use DCBs quite heavily in our practice. Our patients are all CLTI, and we really want to prevent that early restenosis. And of course, you want your bailout stent to be well opposed. So Phillips came up with this diagram, and Mark mentioned it earlier. But it's very similar: pre-treatment, during the treatment, and then optimizing afterwards and checking that everything is right. So I'll show you some cases, and I'll show you an example of when I first started using IVUS. So they're all CLTI cases. Okay, so this lady, 73 years old, some iliac disease, but she has foot ulcers in her right leg, diabetic, renal failure. You can see she has an occluded SFA. Or very, very sort of multiple lesions in the SFA, and then it reforms around sort of P1. Okay, so the aim here is to get her straight line flow to heal her ulcers. The CT isn't that useful. It gives you an idea that it's going to be a tricky case, a CTO, so you can prepare how much time you need on table. The problem with this patient is her vessel size. So in our MDM at St Thomas's, we discussed her case. It's only a 3.1 millimeter vessel. Generally not good for endovascular treatment because we know that smaller stents don't do very well. So the ILX were actually okay in two different views, so there was no need to do anything. But here's the original angiogram. So you already know that you're in for quite a long day. There's sort of a long SFA occlusion, and you saw on the CT multiple calcified areas. Tricky. So this is a runoff. And you can see she's got one really good vessel running off into her foot. Hard to cross, and you can see from my first attempt, we're subintimal, probably ruptured. Haven't just to prove to you that this is quite a tricky case to cross. But eventually, with the appropriate wires, we have managed to cross. Let me go back and see if it will let me play this. Okay, so I'm through here. I'm just confirming with a little run that we're through. So here's the key thing: the IVUS pullback. So I'm asking a few questions. Number one, is my catheter in the lumen? Let's see if this plays. It's a bit disappointing. Probably see it was working earlier. I'll just play it manually maybe. Okay, so it's not going to play at all. Yeah, maybe. Just try and run it again. Don't think that's going to help. It should play now. I think it's going to play. Okay. So here we're in the lumen. Okay, so black is blood flow. So you can see this is soft plaque in the vessel. But as so obviously there's always a pullback. Okay, so there's a lesion here. All this is now in CTO. Okay, NT mentioned earlier calcium. So when you see a big white area and black behind it, that's a calcified area. This is all CTO. The first thing I'm checking is I'm in the lumen. So all the way through, we're in the lumen. Okay, here's another bit. There was another big bit of calcium there, but that was medial calcium. We don't see any major eccentric lesions here. So intimate, see the black is the media, then you've got the adventitious on the outside. Okay, so the next thing we're doing with that same pullback is measuring your reference vessel diameter. So if you recall, her CT was 3.5, no more than 4, but actually her vessel is 4 millimeters distally, and it goes up to 5, sort of mid SFA. So this was a good case for vessel preparation. So here, I decided to use a Phoenix atherectomy device, so 2.2 straight device, because I was in the lumen and the plaque was sort of fibrofatty, soft, and I was in the lumen throughout. Okay, so that's really important. At that point, after atherectomy, it's a balloon, so 4 millimeter balloon here in the SFA, but going all the way up to 5 approximately. Okay, so this is where my practice has evolved. So back then, I'll do an angiogram now to have a look. So here's the angiogram, okay, and it shows that there's decent flow. No IVUS yet. So this is the angiography. No real dissections. It looks pretty good. So then I go straight on to my DCB. Okay, so at the time we were using the StellarX device, so multiple StellarX balloons, because we are very keen on drugging patients, especially with CLTI, all the way up, and this was the final angiogram. So that was our sort of early experience of using IVUS. So we're just using it to ensure we're in the lumen, measure the vessel, use a vessel prep device, and then complete the case. So here's another lady. So she's a frail lady. She's got, again, CLTI of her right foot. She's got gangrene of her third and fourth toes. So I'll talk you through the CT scan. So her femoral artery is open, but then she's got an SFA occlusion here. Okay, so we'll see where the SFA comes back. So quite a similar case to the last one. Okay, but here there's also areas of calcification as well. Okay, and you see that it comes back around P1. So here's her angiogram. Okay, so a short stump, and here's where the vessel comes back, and you see that collateral here. So I won't go through how we cross, but we generally use a combination of, I use the Gladius quite often, the Gladius wire, and then escalating up to the CTO wires like the Halberd or the Astato. But eventually you can see that I'm in the lumen because I'm through into the collateral, done a little check run, and I'm through. And it actually crossed quite easily. So I thought, well, I'm in the lumen here. Let's just do an IVUS, and again, measure the vessel for atherectomy and angioplasty and DCB. So here's the vessel measurements. Have a look at the IVUS pullback. So we're in the lumen here. Okay, bit of plaque here. Nice wide open lumen distally where we've re-entered or entered the Belloni pop. Eccentric plaque here because you can see some calcium. But can you see what's happening here? Can anyone have an idea of what's going on here? Yeah. So. And so some people call it the snowman sign. So here we're clearly subintimal. Yeah. Now that wasn't apparent during the crossing. In fact, it was actually an easier crossing way easier than the first case. Okay, but so this wire is now clearly subintimal, and that clearly changes what you're going to do here. Okay, so you cannot use atherectomy, and now we're back in the lumen here, just here, and this is a CTO. Okay. So it changes the decision making. At this point, well, the only option really here is to angioplasty and see how the vessel looks, with the aim of stenting, because these long CTOs often will dissect, and you'll have a flap somewhere to treat. So having already sized the vessel, I've used an appropriately sized balloon, so a 5 mm balloon here, all the way up to the top, and then here's the angiogram. And you don't need IVUS to show you that this isn't a good enough treatment of a vessel. This needs further treatment, and you can see at the top there's a dissection. But because I already know what my size is, I already know what the reference diameter is of that SFA. I don't need to do anything else. I've already, in fact, got these stents not open but ready. So I've chosen to use a biomimics here because it's more distal. And then on table we have options of alluvia, and eventually I had to use a PTX for the top because of what we had available. But so this is an example of where using IVUS at the beginning gives you much more information that you can use throughout the case. And the difference is here. So I've stented, post-dilated the stent, and what I haven't done now, I've done an angiogram. Okay, so the next thing to do is a pullback. One of the errors you see here is actually, or the video, the way it's done is the pullback is from within the stent. What you need to do is go right distal to the stent and pull back to make sure there's no problems distal to your stent. Okay, so here you can see that the stent's well opposed, it's not compressed anywhere, and we're going right the way back up to the top, right into the femoral artery. A tiny bit of compression there where the calcium was. And back up into the groin. And only then, only when you think you're done, that there's no problems distally, there's no problems proximally, there's no problems within the stent that need improving. So for example, if it's compressed, you might want to use a high pressure non-compliant balloon to open that stent up. Only then do we start doing angiogram. So here is an angiogram right at the top to make sure that stent's right at the profunder origin. And then distally looking for flow. And sorry, I can't show you the actual angiograms, but let's keep going. It keeps doing this, which is very irritating. So you may have noticed she had some iliac inflow disease on her CT. So on the way out, we just treated the iliac artery. Okay, so this patient, a frail patient, she got CFA disease. She's got gangrene of her hallux. And so the plan here was to do a hybrid operation, to do an endarterectomy, patch out her common femoral artery and profunder origin, and then treat this SFA. Okay, so you can see this is a heavily calcified SFA, comes in and out. I must be pressing something. Play that again. So here's her common femoral artery. So it's not me. I'll just show you the angiograms. Okay, so here's the original. Here's the first angiogram. If there's any IT text here, that would be useful, but I'm not sure what I'm doing wrong here. Yeah, might have to. Let's try one more time. It's almost like it doesn't want to go to the end. So here's the angiogram. Look at the IVUS pullback here, if it lets you. It's almost like something else is controlling it. I'll just turn it on and off. I mean, just do this one more time. Okay, so this is the IVUS catheter in a popliteal artery, as you see the pullback here. So you see that this is heavy intimal calcification. You almost lose the intima in the media because the whole vessel is calcified. So we're in the lumen throughout, as you can see here. And there are clear areas of eccentric calcified plaque, and I'll try and pause it at one point. But so there's some soft plaque at the top. Okay, that's clearly some soft plaque. And as you go further up into the SFA, you'll see there an eccentric plaque came in here. Another eccentric plaque. Can you see that coming at 3 o'clock? I'm sort of loath to pause it for you, and then some soft plaque at the bottom here. But so this lesion had a combination of soft plaque, but it also had some areas that were clearly eccentric and really high risk. And you can see here, right here, is a really sort of eccentric plaque just there. So, and these are the lesions that are at high risk of dissection. So maybe you might want to consider vessel preparation. So again, I've sized it, and the sizing is to give me an idea of what balloons I'm going to use and what are my bailout stents and what DCBs I'm going to use. In this situation, I chose to use IVL and targeting those lesions that were especially eccentric. So there was a distal lesion, there was a middle and a proximal lesion. But again, as you know with shockwave, you need to size it 1 to 1.1 at least. With the IVUS, you can appropriately size it. So after POBA, straight to DCB. I haven't gone back to use the IVUS again. So you're not wasting time to have a look and see how is the IVL done, what's the POBA done. In this case, I've just decided to go straight for a DCB, and then see how the outcome is. So here's the pullback on the IVUS now. And you'll notice earlier there was a nice lumen with blood flow. I'm going to shut this down. And if we compare, so if you have a look at the, yeah, pull it off this. How do I get it onto the? But it doesn't appear on this. Might have to pause then whilst I copy it and try one more time, and then. Why would it do that? So I dare not move. Okay. So if you have a look at the difference here, so what's going on in the vessel here? So all I've done so far is vessel prep this with IVL. What's going on inside the lumen now? This is that mid SFA that I treated. That was, originally there was I was in the lumen. You saw the black center. I've not done much here. The ACT is normal. Anyone have any thoughts of what that might be? So black in the lumen is blood flow. So what's this speckly stuff? Yeah. So we've noticed this as well. So if I show you the angiogram, this is how the angiogram looks. Looks wonderful. Looks great, right? There's a wide open lumen. There's flow all the way down. But what we've noticed is that when you, and NT alluded to it earlier on in his first talk, when you see that speckly flow, that speckly flow is actually, there's a problem usually with inflow. There isn't actually good flow through that vessel. It might look good on the angiogram, but even on the angio, you could see with the eye of faith that it was emptying. There was a delay in emptying, and that usually suggests a problem with the inflow. So what we did was with the IVUS, we pulled the IVUS back right to the top, pulled the sheath back, and actually there was a dissection right at the top of the SFA, and that's why there was that poor inflow. So I show you this IVUS pull back one more time, just so you see the difference in the flow. So this was before. This is past the CTO, yeah. So you know, blood indicates there's actually flow going past CTO. As I'm coming up, we will then end up in the occlusion, but all the way through we're in an open lumen. Okay, then here come the eccentric nodules, so there's a bit of soft plaque there. And then we'll compare that to post-IVL and post-angioplasty and post-DCB. Great flow on the angiogram. But the IVUS doesn't look right. So it's not even that subtle. It's actually quite obvious. If you see that on an IVUS, your case is not done, and look for a problem with the inflow. I'm just thinking whether we should just do something else whilst I fix this, because it's quite irritating now. Yeah. And I'll show you a few more cases after Conrad.
Let's do that. Conrad, are you ready to go? All mic'd up. Are you feeling the cold?
Let me take. Do you need this one? Please.
Hi, so I'm Conrad. I'm one of the IRs at Royal Free and at UCH, and it's a pleasure to be here. Just to reiterate this, I think we've seen it now a couple of times. I think the people in the room here are already converts to trying to optimize their outcomes for CLTI. I think it's a little bit of an echo chamber here. So trying to make it a little bit more didactic and learning from our experience. I'm also going to show a sort of a quiz, but I'm going to just start off with a case. So this is a case I performed with Shankar Benogama here at UCLH about 2 years ago now. So it's a video, so we'll play it through and I'll stop it. It's cut and pasted just to kind of show what's going on in this diabetic chap who he's got pretty severe disease, dialysis dependent, lots of ischemic heart disease, older than his years. And that first little bit there is me setting up the room, and just to really show how important it is to make sure if you're going to be considering using IVUS in a case that you actually have got the PIM connector, that's the box I'm holding there in my right hand, close to where your sheath is going to be. It's such a basic step to fail at the very beginning, because you know when you've got the drapes and you've got the pedal and you've got maybe your diathermy if you're doing a hybrid case, there's so much crap in the room. You need to have real estate. So if you're going to have another machine, an IVUS machine, you need to have thought about it a little bit earlier. And as probably echoing what these guys do, the complexity of our angio or hybrid cases, if we're starting to open lots of kit, we open IVUS as well to make sure we use the right kit and we use it to its best potential and safely. And I think this was a case we knew we'd end up probably having to have one and maybe 2 bites of the cherry. So having set up the room, we approached this guy with a 6 French antegrade sheath and did our first angios. And it shows, like in many of these patients, diffuse femoral popliteal disease with multiple stenoses and single vessel runoff. And this is us crossing with an advantage wire. And this is how we set up the actual PIM connector. So we pass it through a hole in the sterile drape and then plug it into that PIM connector. This is the 018 catheter going on here. So this is an over-the-wire 018. It's got a red tip, and this is a different case, but me doing the same thing here with an 014 monorail. And it's quite key just to realize that because it's connected to the PIM box, you've automatically got a reason for a scrub nurse to drop it on the floor, because they try and move it onto the table to wash it or flush it, and then it pulls and they drop it. So I always make sure I have it connected close to the patient's hub, the hub close to the sheath. So we're now going to, having crossed, pretty sure I'm luminal, but I'm going to do an IVUS pullback. And I just want you to concentrate on those images with a live fluoro, and this is how I do it. And Shankar and I then can go through and know exactly where we were when we're doing these kinds of difficult cases. So it looks like a fairly simple just lesion, isn't it? It's just going to all be the same, either calcified or not calcified. Wait a minute. Oh, okay, fine. Wow. As an IVUS lover, this is like kind of rare bird spotting for me. So if I go through that, I want people to, just in their minds, shout out what disease process they are seeing at each point. You don't have to physically shout it out. But if you work at the Royal Free or UCH, I'd be really grateful if you did. So, step 1, sort of P1, just after the adductor canal. What are we seeing? So lots of calcification, yeah, and as Ash was alluding to earlier, you get that breakdown between the media and the intima. Effectively becomes one calcified coral reef. Here, I like to call this bumhole sign. This is where the calcification is almost crimped to the artery closed, also known as coral reef to be less rude. But you've got this real tight, almost vice-like calcification here. As we go further up the artery, you've got what Ash was teaching us about. Everyone shout it out. Sorry, not Ash, NT. Positive remodeling, and you can see that here with the, what color do I press to get the red one? How does this work? It doesn't work. The vessel is trying to maintain its lumen, so it bulges outwards to basically have a sump for the chronic thrombus and soft plaque to sit. As we go further up that vessel, the next station, and this is all in the background of calcification in the media. This lesion here, importantly, what does that show? Mike? Exactly, thrombus or chronic thrombus or fibroelastic plaque, which has occluded the lumen. It's really hard to tell. And this is one of our first IVUS cases. More positive remodeling. And then suddenly you've got, basically it looks like a stent, doesn't it? That's medial calcification. So the next step, once we've done that, is to work out what the healthiest RVD is. Okay, this is a FemPop case, so maybe we've already got a preconceived number in our mind, but that's fine. I'm going to go and stick probably a 6mm or 5mm balloon in this guy. So we do our RVD here. It's a 7mm SFA. Okay, that's fine. Maybe I haven't measured it completely accurately. So we can measure at different points, go up and down, and find exactly where we think that RVD is. Once I have finished that first run, we take it off over the wire. I wrap it up like Indiana Jones, and I put a bit of gauze around just to stop it from falling on the floor, and then I clip it to the drape like this, and this allows me to not have to pass it across the field. So because of the complexity of that disease in that lower FemPop calcified, real tight stenotic calcium, we elected to do a primary 6mm IVL in this case. The reason we didn't go 7, 8 was really because we didn't want to upsize in a not particularly healthy CFA. And actually, where the majority of the disease was that calcified lower FemPop segment. So again, I tend to use IVUS with IVL. I think it's a really good adjunct, and also to see what your benefit outcome is, because the calcium you see on your PAC score or your fluoroscopic sort of assessment of calcium is actually not really helpful at all. In fact, I think it can misinform you. Often where the tightest calcified lesions are not where the biggest lumps of calcium are on CT or on X-ray. So having IVL, this lesion, that FemPop lesion, you can see the IVL doing its magic there, opening up. And exactly where we didn't see calcium, the IVL didn't work. Because the IVL is not an angioplasty balloon. It's a plaque modification device, right? So that lesion there corresponds exactly with the lesion that we expected not to respond particularly well to IVL. And so after this angiogram, I take the criticism that maybe the contrast is a bit too dense here, or it's just a Philips machine, so the X-rays are so much better. If we now compare before and after with the IVUS pullback, you can see all of those areas where it was really crimped calcium. I've got at least 50% luminal gain. Further up the leg where the positive remodeling was, yes, there has been some luminal gain. But the lesion that didn't pop with the IVL, well, nothing happened. Of course it didn't happen. So we performed a high-pressure angioplasty just in that little segment, and perhaps I've slightly missed that there, so we've done it again, and it's overcome. We've done a repeat angio here, and we've actually drugged that with a 6mm impact balloon. With a 2-minute inflation, we kind of did everything we could to throw at it, and we thought we'd done a really good job. And ultimately, we thought we'd fixed this guy's leg. Unfortunately, it came back, the disease, and he occluded at that very point. And it makes me think, well, what could I have done better? And I think now, retrospectively going through my IVUS imaging, and this is one of the best things about doing these courses, or preparing your IVUS cases for talks at Link or at your local conferences, is that it makes you scrutinize your own imaging, and it makes you realize the mistakes you made or the things you missed. So it's a bit like, I don't know if any of you have, so I'm in the middle of doing my PhD. I'm doing it later on, and it's a painful process. From a sort of an IR perspective, I've been a consultant 6 years. I feel like I know what I'm doing. I'm still learning, of course, but from a research perspective, I'm back to like ST1, FY1, learning the basics of how the research world works. It's like that with IVUS, but with a kind of a kick up the bum, because you already can do angios. So when you start using IVUS, don't expect to be able to do the complex plantar pedal loops that you're able to do with a wire straight away when interpreting IVUS imaging. You're allowed to not know all the answers straight off, and to basically fumble a little bit in the dark and make mistakes. And the very fact that you're here shows that you're willing to learn. So do I have time to do a couple of quiz questions? So I would I'm going to do this quiz again at the end of my breakouts tomorrow. And the idea is that I want you to have improved. So if you want to just join slido.com on your phones, you can then vote, and it's quite nice to sort of see how everybody's doing. I'll give you a minute to do that, or you can just take a picture of the QR code. And I think there's 2 Wi-Fis, but the conference one's a bit quicker. Whilst you're joining, if anyone has any questions, hello. So when I repeated the IVUS pullback, there was so much noise because it was all new information. It's like, as a piano player, then adding your feet in, right? And I hadn't noticed, because of all the noise of the white calcium, and Shankar and I had spent a lot of money on this guy already, and he was moving, and we wanted to get him off the table, right? So we felt it looked great on angio. And if you scrutinize the IVUS later, you can actually see still a significant amount of junk in that fibroelastic lesion, even though it looks good on angio. And the problem is the room's bright, you're tired after a 3-hour case or 2-hour case, and really sometimes turning the lights off, moving away from the angio room into the side room and going on the computer and looking at it on the IVUS monitor with the lights off, you start, a bit like ultrasound, a bit like x-ray, you see more when you change your field of view, basically. And actually, I think perhaps in retrospect, there was not as good luminal gain as we wanted. I don't know if that's the reason why it went down. He's had aggressive disease. Just to say, we brought him back, we treated him, and I saw him last week, and he's walking around now complaining of his heart. So that's a good thing, right? But I think it is, we are learning. So everyone joined or tried to join? Good. So what is indicated by the white arrows on this image? How do I know when people have voted? Oh, okay. Wow. Leaderboard, JJ won. I think I've done the wrong type of quiz, haven't I? Has only one person answered? No? Okay. Yeah, you can just put Royal London vascular surgeon. And we won't know who you are. What structure is the IVUS catheter tip in? It doesn't matter, you can just shout it out. Yeah, it's a sheath. It's a sheath. So if you go through a bright tip sheath, sometimes the bright tip bit is completely IVUS impenetrable, but then the rest of your sheath you'll be able to see through. And particularly with the really thin-walled radial sheaths, the slender sheaths from Terumo, you can see through them completely. Good. JJ, you might. Okay, where is the IVUS catheter? Could we just turn off those lights? Is that possible? Might be easier to see. Yeah. So hands up for so what for Slido? Hands up for luminal. Hands up for subintimal. Yeah, it is subintimal. It's quite subtle to see, but this little bit of intima here, sneaking around here, that's a sort of a semi-snowman. I think we're going to find out what JJ put in a second, aren't we? This is another example of, that is the example there. So I've drawn around the 2 lumens. So this snowman's got a bigger head than body. Where is the IVUS catheter in this example? Hands up for luminal. Hands up for subintimal. Hands up for in-thrombus. Yeah, also subintimal. This one's a bit more convincing. You can see maybe this is the head of the snowman. And this is the problem like in the SFA or in the iliacs. The catheter is smaller compared to the lumen of the vessel. But when you're in the popliteal and below, it's so big, the actual head of the catheter, that you can get a little bit blinded. So here is the intima coming around here, and here is the compressed lumen, which is full of plaque or thrombus. There we go. Good. Fine. We can try this again later. So what structure is indicated by the white arrows? So if you're listening to NT, you'll know what that is.
Sorry, I think we had a question just then.
No. He just is telling me how to use Slido because I cocked it up. What structure is indicated by the white arrows? So who thinks that's a perforation? Anyone think that's a dissection flap? What about a side branch? or collateral? And is that normal IVUS artifact? No, that's the trick question. So you never get that artifact in the steady state Phillips IVUS. That's the kind of artifact you get on the coronary rotational IVUS because of the thingy normal directional rotational whatever it's called. I don't know what it is, sorry. But this is a side branch coming in. It's actually really useful if you want to tag your fluoroscopy images from the angiogram to where you are exactly in space in IVUS. A nice example being if you're trying to find the origin of the perineal artery and you're down an occluded TPT, you can actually see where the PT or the TPT perineal AT come off as you go through antegrade and retrograde and pull back. You can actually see the origin of the occluded or sometimes side branches. You then do your angio and go, right, that collateral is at, I don't know, that point in the fibula. I will draw on the screen, and with the Phillips system, we have an integrated system, you can draw a line and then say that's exactly where I expect to find my perineal. And then you can take an angled catheter and plug in exactly there, as opposed to basically looking in the dark. Because a lot of these patients have distorted anatomy, or they have big collaterals that might look like a PT, and you start digging down something which never goes to anything. Finding the hidden perineal origin is a good example of that. And finding an aberrant origin of an AT is another good example, where you never had a hope in hell if it comes off high takeoff in the middle of the popliteal. So it does work. Well, we can do this for this is just a trial run. So what is the RVD of this SFA? Obviously, I have a stupid bonus question because I've given you the answer, but so who would, let's say you were just going to POBA. Who in the room would put a 6mm balloon in this 8-year-old gentleman's SFA? 7mm? 8mm? Yeah, I mean, I think 7, 8 is reasonable. The maximum dimension is 9. And then, so I think if you look at the actual luminal narrowing, you can do this very, very quickly with just dots. So you draw dots around the external elastic lamina, and you draw dots around the lumen, and it will tell you the percentage narrowing. There is a really nice Japanese paper that actually looks at the mean vessel area, luminal gain, and they actually have done an area under the curve which shows the optimal number for the SFA is 19 centimeters cubed or whatever it is. So that's the next paradigm, actually using that cross-sectional data as a guide. We're not quite there yet, but here at least I know that this is a lesion worth treating. Okay, I can eyeball it and say it is, but I actually know exactly how stenotic it is. Hit me. Really good question. Yes, because of the rest of the lesion in this guy, the rest of the pathology in this guy.
The paper you mentioned essentially shows that with further increase of MLA more than 18, the risk of stenosis doesn't decrease in a straight line across, right? So even if you maximize mean lumen area above 18, the risk of rethrombosis and stenosis does not increase perpendicularly, doesn't sort of reduce. You know, as it's not an inverse correlation, right?
So the question here is,
there's a maximum MLA benefit that you get if you go above the study that you quoted.
Yeah.
Shows that if
it's a dolphin study,
the minimum the MLA, if it goes above 18 or 19, the risk of restenosis doesn't reduce.
But their outcome there was binary restenosis, wasn't it?
Yeah.
And not TLR or, and I think they're treating a slightly different population. I think I'm using this slide. It's a really valid point, and I'll show the paper later. But I think the learning point from this is actually how much bigger that SFA is. So if I was going to plonk a stent there, I'm not going to put a 5.5mm superior in there, for instance. Good. So should we do one more question? Oh, that's a bit boring, that one. That's boring. I think you guys already know a lot of this, which is quite nice. I would like to show you. This is my last one. So, this was a patient treated as an emergency in another country, not Germany or England, or actually anywhere for anyone in this room. And they were treated empirically for thrombosis of the common iliac artery. So I've used the 18 IVUS here, and I've done a pullback, and we are in a stent there. That's a stent graft. And as we come towards the bottom of that stent graft, we then kind of, the bottom of our run here ends in the bifurcation of the common iliac artery. That's the bifurcation of the common iliac artery. And then we're into the external iliac artery there. So it's a sort of a really simple question, but what is the problem with their strategy of how they treated that? I mean, majorly too small. But in a 70-year-old woman, a 7mm stent doesn't seem too unreasonable, right? That's like, yeah, okay, fair enough, like within the margin of error, 1mm here or the other. But more so than just it's an undersized stent, the error of an undersized stent is this process that you see at the bottom. And in the fornix up the back of the stent, there's the dead space around where the undersized stent meets the normal vessel. All this thrombus forms that then starts to kind of come over the end of the stent. I don't know if any of you treat dialysis circuits, but this is what we see when we stent the dialysis circuit. You get this encroachment at the end of the stent, which is what then you lose your stent or your graft over. So that's the process. That's. So I think the learning point there is an undersized stent can actually be more of a pathology than a perhaps a badly positioned stent. So healthy to healthy, sure, but also get the right size. So the reason we used IVUS here is because we weren't really convinced why on angio there was a problem at all. She had good flow, but actually it was just undersized, and there was thrombus forming around effectively almost like a dissection, flapping over the distal end of her stent. So yeah, okay, we can all criticize each other when we start looking more, but actually if I would have done exactly the same thing as that individual who had stented her before, but then we ended up putting a 9mm stent in that, which was the appropriate kind of, we tubulated back out again, symptom-free. So I have other cases which we'll show tomorrow. And I thank you for bearing with me with the Slido. It'll get better tomorrow. Clearly today is the techie boo-boo day, and then tomorrow it'll all go swimmingly. So, any questions? And we move it back to Ash.
So, any questions there, or we'll hopefully get Ash's talk running again?
Just whilst we're doing that, I can find that slide. I think it's where is it? The minimal, this is the Hourier paper, which is the thing that JJ was talking about. It's worth a read, just to see. It was a 30mm squared actually, but where we're starting to understand how to quantitatively, first paper that's really tried to do it in the peripheral space, but I think that's the next paradigm. So thank you.
This works now. It's like real life getting IR to the rescue, isn't it? Yeah, I'll find it. I'll go back a bit. That's perfect. Thank you. So, I'm going to go back to, this is perfect now. So, I'm going to go back to that run. So here's that run that I showed you, the pullback I showed you earlier, where there's this odd speckly flow within the lumen. Just there. And you can see the angiogram just about. There's a lack of, the emptying is quite slow. But, you know, I mean, in years gone by, I would have left that and I would have been quite happy with that, especially with a long CTO. In a hybrid case, you're already sort of 4 hours in. But this isn't something that you should never leave behind. I mean, we've seen that quite a few times now. And if you put the chromo flow on it, there's no actual flow in there. There's no chroma flow, although we're not quite sure what that means. But so here's the pullback after just simply a spot stent at the top, just where there was that entry tail or dissection flap. And you can see, and then with the chroma flow that was absent earlier, you now see flow. We can't quantify this, but if you see that red pulsatile flow in the lumen, that's indicative of good inflow through your stent system. And the run looks the same. I mean, the one thing you can say, it empties faster. But to be honest, I think without IVUS, there's times when we've probably left an inflow problem behind. And quite often in our MDTs, when stents go down and you go back and have a look at the retroscope, you notice, there might be a dissection flap at the top, and that's where the patient had a problem. So she did very well. So this is my last case. So we've spoken about flow and lumen gain. So one of the things we've come to learn in recent times is actually for tibial work, IVUS is especially useful. So the one thing we do know is that time to healing is better when you have IVUS-guided interventions. But interestingly, reproducibly, when you assess the size of a tibial vessel compared to conventional angiogram, you'll size the vessel more accurately, and often it's bigger. Okay, so and interestingly, this paper talking about looking at tibial dissections. One of the interesting things that came out of this paper was that routinely the tibials were at least 1 millimeter bigger in diameter with IVUS than on angiography, and that counts for a lot in the tibial segment, especially when you're using things like high pressure balloons, non-compliant balloons, and you want to be confident of getting that size right. So this patient again has CLTI. Previous amputation on the right-hand side. So I'll play you the CT scan, and actually this patient has really good iliac inflow, a good SFA pop segment. So wide open femoral artery. SFA is pretty much normal all the way down, and then you'll see that where the problem is with the tibials. And these lesions in the SFA, the value of IVUS is you can have a quick look with a pullback and just be sure that those lesions are not significant, and then crack on with the rest of your case. So, you might not be sure on a CT scan, should I treat it, shouldn't I treat it? The IVUS gives you an objective assessment straight away of if that lesion needs treatment. So here is the angiogram straight line all the way down to the popliteal segment. This lesion we assessed on IVUS. That was non-significant, and here's the pullback. So now the IVUS catheter is in the tibial. Here's IVUS in the anterior tibial. So heavy calcification. This is sort of a medial Monkenberg sclerosis with sort of intimal but also medial disease. Still in the anterior tibial artery. Putting it all the way back. In the moment that you'll see the TPT. So here's some disease of the origin of the anterior tibial artery. Still in the anterior tibial artery. And then I've sized it. Okay, so this is that lesion that I mentioned earlier. So we're looking at that distal sort of P2 lesion. And again, by doing an RBD and looking at the stenosis, that was not significant. But this was the size of the patient's anterior tibial artery origin. So here it says 6 millimeters. So sometimes what we have noticed recently is that the tibial vessels are a lot bigger than what we're conventionally used to. We're used to 2, 3, at most 3.5 millimeter balloons, but certainly at St Thomas's we're going 3, 4, and even bigger at the anterior tibial artery origins. So here's me measuring that P2 lesion. So you get an instant result straight away that this does not need treatment, and maybe a bit distally it did need treatment. So here's what we decided to use. So a 5 millimeter POBA in the sort of P3 segment going into the anterior tibial artery origin. And because we have a really good idea of the true vessel diameter in a very heavily calcified lesion prior to IVL and prior to the E8 being available, for example, the option here is really a high pressure non-compliant balloon. So I was able to use an appropriately sized jade balloon, and I think that was a 4 millimeter jade balloon in the sort of mid-anterior tibial artery. At the time, we were running the success study, which was using Limus balloons as DCBs. So here we've used a 5 millimeter solution in the anterior tibial artery origin, which is no way I would have done that prior to having IVUS available. And even going distally, we're using 4 millimeter DCBs in the tibial segments. And as a result of that, you get excellent sort of luminal gain, and really good straight line flow into that patient's foot. And I don't think without IVUS, if I used a 3 millimeter balloon, 3.5 maximum in the AT origin, would you see a result where you have a massive wide open lumen? I think especially now with the advent of IVL, we can certainly size these cases much better than we otherwise would. So. To summarize, and apologies for the technical problems. So I use IVUS throughout the whole case. I use it at the beginning to size my vessel, to assess what the plaque type is, and determine which lesions I'm going to target, and which lesions need vessel prep, and which device is best for that segment. It's not often that we use IVL and atherectomy at the same time. So, you can decide which are the lesions that need more TLC and which lesions can you just get away with POBA. Hence, managing vessels on a lesion by lesion basis. And after the case, when I'm checking my outcome with IVUS for quality control and bailing out where needed without any angiograms, looking for stenoses, looking for dissections, treating those first, and at that point, when I think I'm really done with the end of the case, a final pullback, I'm happy, and then a final angiogram. So really, 1 or 2 angiograms should often be enough for these sort of simpler cases. And as a result, we've seen that we're using certainly less contrast. And the good thing for us is our radiation exposure is also reducing because we're not doing multiple DSAs. And I think it's great that you're all here. I think there's certainly a need for further education on how to interpret these images. So to go back to the original my original images, so we use IVUS a lot, and the key here is to use it effectively. So I'm going to go back to football again. If this is for the German colleagues here, if England had if we had VAR during England's World Cup against Germany, I think we would have won that game. But Frank Lampard's goal wasn't counted, but clearly it was a goal. And it was also, you have to trust it as well. So if you see something on IVUS, it can't be anything else. You've got to trust what you see. There's a temptation to use IVUS and go, well, the vessel says 5 millimeters, but I'm going to use a 3 mil balloon for the anterior tibial. You just got to trust it. So going back to my team, Liverpool, back last season when Diaz scored a goal and it was disallowed because he was offside. He was actually onside with VAR, but the referees didn't communicate, so they called it offside, and Liverpool didn't win that game after all. So I think it's really important to trust what you see. And then I think we'll talk about it during this workshop. Maybe ration it. So in cricket, you only get 3 VARs or DRSs, right? So you only get 3 chances to look at the imaging to see whether it's true. So maybe we need to decide which are the right cases to use IVUS for, and which cases can you get away with this, our general techniques. And I think the idea that task AB lesions don't need IVUS, maybe when you're first starting off, they're the good lesions to use IVUS on, because you'll have a nice healthy segment above and below. You'll treat your lesion and you'll decide whether you're going to spot stent it or not spot stent it, and then you have a nice healthy segment to choose. I'm going to stent from here to here, and here's my sizes, and you're using IVUS really simply. And then as you go on and you start using IVUS more and more, you might start going for the more complex CTOs and then going for the tibial vessels. So apologies again, but got there finally. Thanks.
Any questions for Ash? Mike.
Do you think as you've used IVUS, so as you've used IVUS as you've gone along, do you think there's cases now that you won't use IVUS on because you've used IVUS? So you're more selective? So
possibly. That's a good question, actually. So, so we do quite a lot of stent occlusions. So with those, the wire is going to be in the stent no matter what, because you loop a wire down and you can get through the stent. Now, providing you're happy with the outflow and your aim is just to treat the stent itself, I think those ones you can get away with an atherectomy, laser, whatever your plan is. It's the flow that counts here, and then do an angiogram and be happy. Sometimes, quite often, there's a technical problem above or below a stent. So maybe in those situations, you might want to check with IVUS distally. But if you're happy, actually that lumen's wide open. That's an easy case to not have to use IVUS on. But apart from that, I've got to say for below the groin cases, I'm a bit more than Mark and NT. I'm sort of 75% IVUS. I'd say for iliac cases, I hardly ever, if not ever, use IVUS. We do for vessel preparation. So I think you might have heard this mantra. If you're going to vessel prep, I think it's so important and it's so useful to use IVUS in terms of the cost effectiveness of your vessel preparation, because your plan is to vessel prep and then DCB most likely. So the cost of that IVUS is a small portion of the total cost of your case. So, but maybe even for the iliacs, if we're using IVL, I would use IVUS to get that size correct. And you might argue that actually on a CT you can plan the size of a vessel, which I also agree with, but also often we're trying to improve lumen size with IVL. So with IVUS you get the area, and the change in area equates to an improvement in flow. So we use IVUS quite a lot for looking at the increase in luminal area rather than just looking at stenosis after IVL for the iliacs.
And do you want to get Becky set up while I'll add something on to that as well. I think a lot of the time in deciding whether or not to use it, I try and walk through the case before the patient's on the table and think, what is the best thing for this patient to end up with at the end of the case? So say, a 90-year-old with bad lungs, rest pain, not really fit for any kind of anesthetic stuff, with a long calcified SFA CTO. They need a very quick access, cross, stent, get out quickly before their lungs go or their leg drops off the table. For them, I know I'm going to access, cross, probably subintimally, get a re-entry device if I'm not back in 30 seconds, and put a supera in. There's enough information on the CT to make all that call. The IVUS isn't going to change what I'm actually going to do in the procedure. Let's not spend the time. Ditto, say, for example, if it's somebody with small distal tibials, and I've got a decent duplex, and I know that this tibial is sort of probably definitely no bigger than 2 millimeters. Again, what am I going to do? I'm just going to cross 2 millimeter balloon and get out. It's not going to change the decision. When the tibial vessels get larger, when I know they're going to have an amputation that's going to result in a larger wound, for example, a transmet or multiple digits, where I need the revascularization to stay patent for longer to allow time for tissue healing, then maybe IVUS. So there's a lot of inputs that go into that decision making. So I can give you that kind of, okay, I use it in half of my cases, but I think the key comes to every case you do. Imagine before you start, all things being equal, what would this patient come off the table with, both in terms of technical, anatomical result and suitable for the rest of them? How quick do you need to do things? And then see where the IVUS fits into that, whether it's going to be something that's useful or not. Just very quick straw poll. How many people here believe in DCBs in the tibial space? Very few hands. One here. Yeah, no, it's interesting, isn't it? I mean, I mean, I don't think we can trust any of the data that's come out from all the original DCB trials, because when we know what we know about sizing now, I'm sure a lot of those DCBs in the original trials were undersized. So I'm happy to say I don't know, because I don't think we have any actual relevant, useful data in this space, knowing what we know about sizing now. But let's see, we'll look at some more cases together over the next day. All right, lovely, all set, ready to go? Thank you. So this is my colleague, Becky Sanford. She's a vascular surgeon at St Thomas's. Big open and endo practice now, I would think fair to say, and going to talk to us about how IVUS changed your practice.
Thank you very much, NT, and thank you to Philips and Ash and NT for inviting me to talk. I have to say I feel a bit of a fraud. As NT says, I am very much not an expert either in IVUS or in peripheral endo or in CLTI or anything else. I am a general jobbing vascular surgeon. But I guess my role is to say, well, even within that generalist practice, how have I come to adopting IVUS, and in which cases, and where is it useful on that sort of early point of a learning curve? I am very conscious that a lot has already been said, and we've had a bit of repetition in the stuff that we've talked about already, so I'll try and go through things fairly quickly. I'm also very conscious that I'm the only thing that stands between everyone and beer, so I will be as brief as possible. So, as a generalist, why use IVUS? And I'm not going to go through all the data that we talked about, but there were a couple of things that sprung out to me. The first is this one, which is the Medicare study. There was 500,000 patients in this study. Only 11% of them, not 11 patients, 11% of the patients had IVUS used during their procedure, which tells you something about the selection bias in how those outcomes have been drawn, because they're probably the high volume users who've been using IVUS. But there was a 27% reduction in major adverse limb events at a 2-year mark. That's quite powerful to me, speaking as a generalist who cares about clinical outcomes and probably a little bit about how we deliver good, high quality care within a public sector health system. So that paper sprung out to me. And the other one that we've talked about as well several times this afternoon, I think tells us a little bit about how IVUS is achieving those outcomes. So this is the Allen, this is the randomized trial, and basically looks at bigger device sizes and bigger treatment lengths. So I think if you put those two things together, you can kind of build an argument for why this might be better for patients and also cost effective in a public healthcare setting. So as a generalist, it's convincing. So when? So I've heard people talk about lots of different applications, and I'm aware that most people in the room actually are really experienced operators in the aortoiliac segment, in the venous segment, and in the CLTI segment. For me personally, I found it the most useful in the SFA POP segment. And that is because, one, I find it the most challenging to treat, and two, there's the biggest range of treatment devices. So I find that it helps me to work out what my ideal treatment algorithm for that patient is going to be. And of course, I also have the benefit of working with Ash and NT pretty much every Friday. So I have a masterclass every week in algorithms for using IVUS and CLTI treatment. So the 4 phases of care, we've talked about this sort of the pre-procedure, peri-procedure, and post-op checking. Another way of looking at that. I assess my crossing with it, think about sizing, define my treatment zone, and then quality control. So I've just brought a couple of cases that illustrate those different phases and where I've made decisions based on it. So assessing the crossing. So this is a case I did a couple of weeks ago. I'm going to present many of my failures, because of course you learn more from failures than successes, so bear with me. So this was a recent failure. So this lady had CLTI, she's only 67. She had CLTI with rest pain, nasty diabetic tissue loss with dry necrosis. And she's got this SFA occlusion. She is only 67, she's not the fittest of a fit, and it was a single segment occlusion. So while some people would advocate bypass in that scenario in a youngish patient, actually we were going endo first. But my plan was to try and cross luminal and then to leave nothing behind. So luminal, potentially vessel prep, and DCB. That was my plan. So I come to the crossing. Now, the crossing was not as easy as I'd anticipated or hoped. And I went through my range of delicate little 014 CTO wires to try and get across. But I struggled, actually. This was the crossing IVUS, and I'll just let these play through quickly because I think everyone's seen quite a lot, but you'll see here that I'm subintimal in a couple of areas where I had hoped not to be subintimal. So then my whole plan for the case has to change because my crossing isn't what I wanted it to be. So that's just reiterating that I'm not where I want to be. So at that point, I know I'm not going to use vessel prep. I'm not going to use atherectomy in this patient because I've not got the crossing that I wanted. So then the next thing I do is to work out, well, what's my plan B? And for me to work out my plan B, I wanted to know what the vessel size was actually. Because the simplest thing to do, and probably the most conventional, bearing in mind I am not a CLTI peripheral interventional specialist, I wanted to do the most conventional and predictable outcome for my bailout, if you like, which was to say, can I stick a stent in this? Is it big enough that I can stick a stent in it? And it was a 5mm pop and 6mm further up. So I thought that was very reasonable to treat with a stent, so I stented her. Now, you will see on here, for those of you who are astute, we did treat that as well. This isn't actually the final run. And actually, she had slightly sluggish flow down here from some spasm in the PT, which all opened up once we got her off table, and she's got duplex scan, which looks whistle clean. Her tissue loss is healing, her rest pain is gone. So it's an example of a failure, because I didn't get the crossing I wanted. But actually, the strength of the IVUS was in telling me not only don't use an atherectomy or a vessel prep device that might be dangerous in that space, and two, what's your best bailout, or a reasonable bailout. There are lots of different things you can do. So I used it at various points in that case. So vessel size, this is an interesting one that I did maybe 18 months ago. This lady is 83, 84 with circumferential ulceration, rest pain, and again, an SFA lesion. And again, I mean, I'm always trying to cross intraluminal. I don't always achieve it, but I'm always trying to cross intraluminal. And again, this was a mid-SFA lesion, short lesion. Crossed, actually this time I did manage an intraluminal crossing, and again, I've used the IVUS just to confirm that I am intraluminal and I can use whatever I want to use. And actually for this one, I just did a plain balloon angioplasty and then a DCB. And you can see I've sized it up on IVUS, and I made that a 5mm vessel in various different points. But on my angio at the end, it looked to me like this area was running really nicely, and this just looked a bit underfilled. So I went back and re-IVUS'd and actually got it consistently at 6mm. So then went back to a plain balloon and did a 6mm plain balloon throughout it all, and actually got a really nice run through that segment. So I suspect, I mean, I may just have undersized the measurements to begin with. It's entirely possible that that's just a learning curve of sizing it. But I think just looking at that angio, and again, the guys will say you transition a bit from using angio and cross-referencing all your IVUS with angio as a sort of learning curve to being able to just trust what you see on IVUS. I'm definitely at a stage of still hitting the pedal a lot and wanting to itch and do in-between angios a lot, because I know how to interpret it a bit more. But seeing that, I could immediately cross-check it. So I thought that was an interesting phenomenon, and it may well have been that the vessel opened up a bit more just by getting more flow through it. The treatment zone, so this is a case that will long live in my mind, and it was a case that the three of us did together. I think we made you miss your mate's 40th birthday dinner, actually, because I think we were still there at 10 o'clock at night, and it was a horrible calcified, long calcified occlusion in a chap who'd had bilateral CLTI. He had had common femoral endarterectomy and iliac stents previously. He then had circumferential necrotic deep ulceration, rest pain. This guy's only in his early 60s. But just didn't have the tissue quality to even contemplate doing any distal bypass. So we were doing a very long, full-length SFA pop calcified occlusion. We used IVUS throughout the whole case. I'm using it particularly to illustrate the example of when to stop, actually. So I'll skip through these bits a bit, but there are some quite nice, pretty images. So you can see that you've got a full length. That's the stump from the previous common femoral endarterectomy, and then you've just got full length occlusion through the SFA and comes back in the distal pop. We ended up, I think Ash was at the top with the back end of a Terumo at one point. we were down at the bottom trying to get AT access. So you can see here, this is really nice. So this is the retrograde IVUS, which is luminal, but it shows the wire from the antegrade in the subintimal space, and then the reverse when you put the IVUS from the top. So it was a really nice case of using it the whole way through. As I say, we're keeping you from beer, so I won't go through every phase of it because it was long and difficult. But essentially, we got through luminal and then treated with IVL and POBA to see what we were then going to do next. and then stented because we had some recalcitrant stenosis. This was the one that I wanted to show you. Just watch the early bit of this run because we're obviously doing a pullback. And this is about defining your treatment zone. So you'll see, this guy's got disease from his heart to his big toe. But knowing when you can stop is also important. And if you look at the bottom end of that stent, I'll play it through again. If you look at the bottom end of that stent, there is some resistant disease in this below-knee segment, but it comes out as less than 50%, and so we could have the confidence to leave that, knowing that it was flowing well, it was non-flow limiting. And so defining that sort of treatment zone, I think you do get a lot more subtlety to that than just looking at an angio and trying to say, well, is that flowing well or not? So that was the reason I brought that case as an example. This is obviously another absolute triumph on my behalf. So assessing outcomes. So this was a chap with a popliteal occlusion. He is, again, young, so 65. He's had a recent hemorrhagic stroke, and the neurosurgeons have told me in no uncertain terms that he can have nothing more than aspirin for his antithrombotic therapy. He's got CLTI, rest pain, and a lateral malleolar ulcer, necrotic ulcer. And again, so this popliteal occlusion, which I was going to try and treat. But my preoperative plan going into this was basically POBA, because I couldn't use dual antiplatelets, so I felt a bit sort of hamstrung about using any of the fancier techniques. I didn't really want to atherectomy without being able to give him clopidogrel. I didn't really want to stent because it's not a nice bit to stent and I'm not going to be able to up the antithrombotics. I didn't really want a DCB without being able to give him clopidogrel. So I pretty much thought I'm going to just try and get across this and POBA it. And I managed to cross luminally, and then size the vessel on that. My eyes are a bit too small to remember what it was. 4.5-ish in the distal segment, so not huge. So I POBA'd it and got that. So my heart sank a little bit because it's all dissected and horrible. So I just did a prolonged balloon inflation because I wasn't really sure what else I was going to be able to do and sort of kept my fingers crossed. And then got this, and it was flowing really nicely and filling into his foot really nicely. And I thought, oh, great. I've already made my decision at this point that I've got flow, I've got lumen, and I can't give him anything more than aspirin, so I am going to stop. But then I did the IVUS to see what it looked like. And this is what it looked like. And I sort of started looking at it thinking, oh, okay, yeah, good. This one plays a bit slowly, sorry. But like in my mind, fairly shortly after this bit, I started to hear like the horror music in the background in my brain, where you see the huge dissection and residual disease with this tiny little flow lumen that comes in just a second. So you start to see that, and I thought, oh, that's not looking great. You can see I've sort of stopped as I'm putting the IVUS catheter back while I'm thinking, oh my goodness, what am I going to do with this? And then it sort of gets smaller and smaller, and then opens up again a bit. You can see that speckledy flow around it that we were talking about. There probably is some flow effect to this. And then just watch what happens next. And it just narrowed down and down and down and down and down. And I thought, oh, cripes, what am I going to do with this? I'm really not sure what else I can do. I've already done a prolonged balloon inflation. I've got flow. I can't up the antithrombotics. I think I am going to have to just stop. And to be fair, I think in hindsight, even knowing what happened to him, I'd probably make the same decision again on table. But what I would say is that knowing that that is likely to cause restenosis and occlusion of that vessel, I should have been more on it with his surveillance. So he was supposed to come back to my clinic after 6 weeks, and actually didn't get his surveillance scan for several weeks after that, in fact months after that, because we're a bit behind on our surveillance. And by the time he came back, it had occluded. Now his rest pain had gone and his tissues loss has healed, but I think I missed an opportunity there where we could have brought him back at a month and potentially just gently re-ballooned that and had a longer lasting outcome. So my learning point from that is not necessarily that I would have done something different on table, but the IVUS predicted the point of failure, and I failed to act on that in terms of my post-op care. So I think for me, the IVUS influences both your intra-op decision-making, but also potentially your post-op, and working out who needs that enhanced surveillance or that closer look, or the increase in thrombotics if you can do it. So just to end on a slightly higher note than that. Absolute failure. This was a case that we did very recently where we've used IVUS the whole way through. So again, SFA pop, I'm sorry that it's all boringly SFA pop, but for me this is the most challenging segment to treat. So again, and I must clarify this case before I carry on. This guy was a 67-year-old, and he is a very short distance claudicant, and before you all think I've gone completely mad, he was unable to work. He has stopped smoking. I've managed him conservatively for 2 or 3 years. He takes all his medications and he's really struggling, which is why I'm intervening on a claudicant. But he's got this SFA occlusion. I've managed to cross it intraluminally, thank goodness. The question, if I hadn't crossed it intraluminally, might have been what to do next. And in a claudicant, probably the answer is stop and come back another day, right? But we're through the lesion. We confirm that we're luminal with an IVUS. We've then sized according to the IVUS imaging. You get the idea what we've done next. So then we do the completion IVUS, and actually this runs through it quite quickly, which is why I've given you the static shot, but we have got a dissection on that. And again, a bit like the long complex SFA chap, this was quite a nice clear image of the dissection and enough to say, actually, although there's a bit of dissection there, this is not going to be significant and flow limiting, and we can leave that because it's small and it's not deep. So we don't need to stent him, and obviously in a claudicant I was quite keen not to stent. And we've got good flow on the completion angio, we've got single vessel runoff, so we just didn't do anything with this, and it's flowing well, and his symptoms have improved, and he's now back walking, working. So in conclusion, even in non-expert hands, I think IVUS helps me to improve the quality of what I do, both on table and potentially post-op. I think it does improve the quality of angios that I can provide so that I can hopefully treat a patient once and well, and that potentially has benefits for that individual patient, but also potentially for the health system if you're not bringing people back for repeated interventions. So even in non-expert hands, I've found it a really useful adjunct to my practice. Thank you.
Cool. Any questions before we break for dinner?
Quick comment, actually. Thanks, Becky, I think you're being incredibly hard on yourself. Talking about that being a complete failure, the purpose for intervention on the man with the neurological trauma was to relieve the rest pain and heal the wound, which is an outcome you achieved. And then subsequently, if the vessel had gone down, you wouldn't then, I presume, have re-intervened on a non-symptomatic patient.
Yeah,
so I would consider that, under the circumstances, to have been a success.
Well, thank you very much. But you know, these things, you're quite right. The clinical outcomes are the thing that are important, right?
That is ultimately what they are here for.
100%.
So.
But there's, you know, we were perhaps lucky that he hasn't had recurrent symptoms with that scenario. Now, we've gone back to baseline, so he could have another procedure that would be no more complicated than the first time round. Which is, again, the benefit of not having done anything more. You know, I've not stented him, I've not left him with something that would give him a more complex re-intervention. But yeah, not your finest hour, eh?
I don't know, I still think that the outcome there was really good. I mean, clinical outcomes are what matter, ultimately.
100%, is what we're all here for, right?
Any other questions? Perfect. In that case, I think we'll call it a day for today. Thank you all. Dinner is at 7:30 in the Milkarai restaurant just around the corner where we had lunch. And then we'll reconvene tomorrow in here at 9 a.m. Where I'll start by talking about vessel prep choices in heavily calcified lesions and how IVUS helps us there. And then we've got some other talks about other vessel prep strategies from Philips. And then in the afternoon, we'll spend some time in the sort of individual workshops going around and getting some hands-on experience with the software. Cool. Thank you very much. I'll try and talk to as many as you possible over dinner and afterwards as well in the bar, hopefully. All right. Thanks.